Dr. Samley. We'll discuss it later. So I would be speaking the right topic. The need for achieving the postprandial control, ultra fast acting insulin, and then do we need it and do we have it? So all of us know, yes, we have a basal and bolus insulin release which is happening physiologically. So the basal release is because of the hepatic glucose output which is there for the 24 hours, and then every bolus is happening with all the time with all the major meals. In diabetic patients, they are exposed to this glycemia basal and postprandial. So they have a hyperglycemia which is there in both the states. They have a basal as well as postprandial hyperglycemia. You can see that in this slide. Most of our day, I think, right from morning, if I would just take few seconds, intermittent fasting, keto diet, whatever it is diet. So even if you're talking about intermittent fasting, we are having something at least. And then keto also we are having, even if you're debating, we are still having. So most of the time, you will see that we are spending 16 to 18 hours in that postprandial state. So this is, of course, not a kaun banega karodpati, nor do I have prizes because I am not lucky as these postgraduate students are. Can anybody tell me what is the time at which glucose excursion reach peaks after Indian meal? So now all of us have had our meal. What do you think? It is 30 minutes, 1 hour, 1.5 or 2 hours? 1.5 hours? 1 hour? For Indians, 1.5. See now, of course, now nobody wants to take D, so I will take A. So you will see the common meals as a South Indian, North Indian, the postprandial glycemic surge which happens, you will see is between 30 minutes to 1 hour. So somebody who is taking chapati and dal, the peak is happening at 1 hour. Somebody who is having dosa and chutney. So here we are applying ourselves the pure South Indian. That is 30 minutes. Idli and chutney, yes, we love this. We cannot live without this. So yes, that's again 30 minutes and 1 hour. Pongal is 30 minutes. Puri. Perfect. Next. Chevy. Next. Ferrari. That's an F1 race, Ferrari. So you will see over a period of time, we have always developed right from whatever we had till the best to reach the speed. Same way we've developed from human insulin to analogs and ultra fast acting insulin. So the current fast-acting insulin, what we have, it takes more than 10 minutes, does not reach its maximum concentration in 60 minutes. So current fast-acting insulin is still not fast enough as your Ferrari. So this is the normal, regular human insulin, and then what we had was the rapid-acting insulin, which is trying to touch the normal physiology. And now we have the ultra fast acting insulin again, which is almost mimicking the postprandial peak. So what is this fast acting insulin aspart? There's a few changes which has happened in the molecule. There is a niacinamide which has been added, which helps it to absorb better. L-arginine for stability of the molecule. So most important here, you will see the onset of appearance, it starts within 4 minutes. So it starts as early as 4 minutes and then takes a peak in 30 minutes and then has the maximum concentration at the 60 minutes. So that is where you will see so 74% greater insulin action which is happening in the first 30 minutes. So what we are doing is we are trying to mimic the normal physiology. We are trying to get down the postprandial sugars early so that that state of postprandial hyperglycemia which is causing damage, we are trying to get it down as fast as possible. So onset of action you will see is somewhere around 4 minutes to 5 minutes. And compared to insulin aspart, it has an early onset, greater early and maximum insulin exposure which is happening within the first 30 minutes. And then it is not only that, okay, it is reaching fast and going out faster. No, it is reaching the peak and then it has a similar total exposure. So which is very important. It has a greater early glucose lowering effect and similar total and maximum glucose lowering effect. So out of these, when you have a patient in front of you, in your clinical experience, which of the following is biggest concern for a patient to deal with during insulin treatment? Hypoglycemia, glucose excursions, or inflexible dosage regimens? Hypoglycemia? Ma'am is it all the three? Hypoglycemia? Yeah. See, again, it is medicine is based on guidelines, but guidelines does not tell you to be so strict. It is all individual based. So I think yes, we all might be worried about all the three some part of the time. The most important is the early glucose lowering effect. So you will see the insulin aspart, when we had the insulin aspart, when it compared with the human insulin, it was 38% greater reduction. It was better, but now you see we have a molecule which is 74% greater reduction than your insulin aspart. So faster insulin aspart is having a 74% greater glucose lowering effect when you compare it with the rapid acting insulin what we already had. A1C reduction is 0.1% difference and then 0.15% difference when you compare it. There are 3 trials which have been done, the onset one. So one is, the name 1 is in type 1 diabetes, name 2 is in type 2 diabetes, and then we have one more. Because of the paucity of time and then I get a paper giving me some instructions, I have to go a little more faster. I think my 4 minutes, I might reach a peak now. Yeah. So onset one is done in type 1 diabetic patients who were on basal bolus insulin. One arm patient was on faster aspart, another arm insulin aspart, and another arm faster aspart. The most important thing here is you had given both the aspart, but here one time it was given with the meal and then there is another time which was given post meal. Type 2 diabetic patient, again, onset trial 2 is in type 2 diabetic patients who were uncontrolled on oral hypoglycemic agents, on metformin. So there was a run-in phase after which patients were put into the faster aspart and insulin glargine. insulin aspart and insulin glargine, so metformin was continued. So in type 1 study, there was a significantly better A1C reduction with mealtime faster aspart versus conventional aspart. We know that, yeah, because it is acting faster, so you expect that. In type 2 diabetic, yes, there was hardly any change in the A1C. So there was not much change in the A1C. But the postprandial peak at 1 hour and 2 hours was less in patients who were in type 1 diabetic patients. Again, the first hour was more reduction in patients who were on faster insulin aspart, even in type 2 diabetic patients, when you compare it with the regular aspart. Onset 9 trial design, so this is a double-blinded randomized treat to target. Key inclusions were again type 2 diabetic patients who were on basal bolus regimen. There was a run-in phase of 12 weeks, and then patients were divided into faster aspart with basal insulin and insulin aspart with basal insulin. So this clearly said the non-inferiority. So it said that both the molecules, when comparing it to the A1C, it is same, but the postprandial glucose increment. This says there is superiority at 1 hour reduction of postprandial is better with faster acting insulin aspart than with the insulin aspart. Again, this is very, very interesting slide. We were hearing some answers on hypoglycemia. So when you see that 2 to 4 hours, it favors mostly the fast acting insulin aspart because it has already reached its peaks. Only at 1 hour it is in favor of the regular aspart. But if you're looking at the overall rate of hypoglycemia, it is favoring the fast acting insulin aspart. So to summarize, fast acting clinical aspart is faster and effective. It is superior to reduction in post meal glucose excursion. It is safe. It has a better safety profile. So this is very, very important. We want an insulin which we can give it to across the spectrum. So you can give it in pregnancy, you can give it in renal patients, patients with hepatic impairment as well. And then the lesser rates of severe hypoglycemia. So the events of hypoglycemia is also less. So you have a molecule which will help you to control sugars. Chances of hypoglycemia is very less, and you can safely give it to all the spectrum of patients. It is very, very flexible. So you remember that slide where it was given before meal and then after meal. So you can give, in a time like this where we always are bounded by time, I have only 3 minutes because I have already got an indication that health minister might join us. So we are always bound by time. So if I had to take my lunch, and then when do I have a time to take that insulin? So this is the right option. So considering the busy lives of us, it gives you that flexibility. So it gives that flexibility to your patients. This is for the postgraduate. I think all of us sometime would have written this, etc. in our patients' papers. I can see some smiles in the audience. I was always trying to find out what does etc. mean. We had different negotiations, but I have got the answer. End of thinking capacity. That is where I also end. Thank you so much.
So, thank you, Dr. Faraz. Very nicely you elaborated that fast-acting aspart is a better insulin in terms of controlling postprandial hyperglycemia and flexibility of regimen. And you also said that it is non-inferior to regular aspart in terms of reducing A1C and I think in terms of episodes of hypoglycemia. But in one slide you showed that you mentioned that in Indian meal peak comes at 1 hour.
Yeah.
After meal.
30 minutes to 1 hour. Yeah.
And at 1 hour, regular aspart is performing better than fast-acting aspart. Like the slide what you showed that which favors whether fast aspart or regular aspart. So at 1 hour, I think regular expert is performing much better.
Yeah, the peak actually is starting from 30 minutes to 1 hour. So we are trying to target the 30 minutes.
Concerned for 1 hour peak, and that time if regular expert is performing better, then why to go for fast expert? You can show that slide.
Yeah. No, I get the slide. Yeah. I think,
What ratio slide?
sir, can you just give me 2 minutes? I think,
This is just a comment.
no, we will have it. I think the health minister is already here. So I am getting some messages from there. So, yeah. Let me heartily welcome Health Minister of Telangana, Etala Rjender Garu sir, for sparing his time on this auspicious Sunday, taking out time. Sir, please welcome. May I call you on the stage, sir? Please, hearty welcome for joining us.
I request Chairman FDARS Dr. Jalal Farishta sir, President FDARS Dr. Shaista Farishta, Scientific Committee Chairman Dr. Srinivas sir, Organizing Secretary Dr. Faraz sir, Dr. J. Arvind, Dr. K. N. Manohar, Dr. J. K. Sharma sir, Dr. Ashish, and all our panelists on the dais. And IIMR Sridevi Madam. Now I call Dr. Syed Umar. Sure. Gurukul ke bare mein.
I request Mr. Akbar Sahab, please, the chairman of the minorities wing, to please come on the stage. I request all of you to please sit down. Good afternoon, everyone. I request Dr. J.K. Sharma sir to please come on the stage. I request Dr. Arvind to please come on the stage. Good afternoon, everyone. I welcome you to the opening of Gurukul. Gurukul is the educative wing of the Frontiers Diabetic Association. We aim to help doctors and fellow healthcare specialists in gaining the requisite medical information necessary in today's fast-changing medical highway. I request our health minister to please say a few words, please, sir. Mic.
We do the inauguration.
Which one? I request our health minister to please inaugurate the Gurukul. Jao tum.
करने दो, क्या है क्या है एक्सप्लेन करें तो मुझसे सबको समझ में आता ना.
Okay.
पहले एक ऑर्गेनाइजर को बात करने के बाद मुझसे सबको.
All right. ठीक है. नहीं पहले I request Dr. Shaista Farishta to please introduce the Health Minister. Go back to this slide. I request him to say a few words below.
హైదరాబాద్ అనేక డిబేట్స్కి సెమినార్స్కి వర్క్షాప్స్కి నిలయం. संस्थाओं में एक साल के अंदर 2022 कॉलेज अटेंड किए थे. डिफरेंट हेल्थ इश्यूज. एक बड़ा कॉन्फ्रेंस चला था यहाँ पे, इंटरनेशनल कॉन्फ्रेंस चला था. इस देश के अंदर हैदराबाद एक हेल्थ हब बन गया. यहाँ पे जो डिबेट होता है, यहाँ पे जो सेमिनार्स होता है, बहुत 2 दिन 3 दिन लंबा डिबेट चले. चर्चा होने के बाद अपडेट होके यहाँ पे जो पेपर प्रेजेंटेशन कर रहा है, सारे तेलंगाना को बहुत यूजफुल हो रहा है. మీ అందరికీ నా రిక్వెస్ట్ ఏంటంటే, తెలుగు సమస్యనా, నా రిక్వెస్ట్ ఏంటంటే అనేక విషయాల మీద తెలంగాణ ప్రాంతంలో హైదరాబాద్లో ఎవ్రీ ఇయర్ ఎవ్రీ 2 years ఒకసారి మనం సెమినార్స్ ద్వారా ఎప్పటికప్పుడు అప్డేట్ అవుతూ ఉంటాం. హెల్త్ సబ్జెక్ట్ అనేది ఎప్పుడు కూడా స్టాటిక్గా ఉండదు, అది ఎప్పుడు డైనమిక్గా ఉండదు. ఎప్పటికప్పుడు న్యూ ఛాలెంజెస్, ఎప్పటికప్పుడు న్యూ ఎక్స్పీరియన్సెస్, అవన్నీ కూడా మనం మళ్ళీ ఎక్స్చేంజ్ చేసుకోవడం ద్వారా, అప్డేట్ చేసుకోవడం ద్వారా ప్రజలకు మరింత మెరుగైన వైద్యాన్ని అందించే ఆస్కారం ఉంటుంది. ఒకటి డిసీజ్ పరంగా కావచ్చు, 2 మనకు వైద్య పరంగా కావచ్చు, 3 ఫార్మసీ పరంగా కావచ్చు. ఇవన్నీ కూడా ఎప్పటికప్పుడు మారుతూ ఉంటాయి. ఒక మాట చెప్పాలంటే డాక్టర్ ఎంత అనుభవం ఉన్నప్పటికీ కూడా ఎప్పటికప్పుడు మళ్ళీ ఒక విద్యార్థులాగా నేర్చుకుంటూ ఉంటాడు. ఇలాంటి సెమినార్స్, ఇంటర్నేషనల్ జరిగే సెమినార్స్ కావచ్చు, దేశంలో సెమినార్స్ కావచ్చు, ఇవాళ డయాబెటీస్ మీద నాకు తెలిసి గొప్ప చర్చ జరిగి ఇప్పుడున్న ఈ పరిస్థితులలో మనం ఎట్లా మళ్ళీ అప్డేట్ కావాలంటే దాంట్లో ఇక్కడ నుంచి మళ్ళీ రిచ్నెస్ మళ్ళీ ఒకసారి మనం చాలా నేర్చుకోవడానికి సందర్భాన్ని భావిస్తాం. ప్రపంచవ్యాప్తంగా నాన్ కమ్యూనికేబుల్ డిసీజెస్ పెరుగుతా ఉంది. దేశంలో ఉన్న 3 days సెమినార్ జరిగింది. 3 days మినిస్టర్స్ కౌన్సిల్ కాన్ఫరెన్స్ జరిగితే దాంట్లో నాన్ కమ్యూనికేబుల్ డిసీజెస్ ద్వారా 60% డెస్ అవుతుంది. దీని మీద మనం అలర్ట్గా ఉండాల్సి ఇక్కడ ఉందని చెప్పి దానికి మూలం డయాబెటీస్ అని చెప్పి చెప్పడం జరిగింది. డయాబెటీస్ హార్ట్ ఫెయిల్యూర్, డయాబెటీస్ బ్రెయిన్ స్ట్రోక్ దాటిస్తాయి, డయాబెటీస్ కిడ్నీ ఫెయిల్యూర్ దాటిస్తాయి. ఒక్క మాటలో చెప్పాలంటే మనిషి ఆరోగ్యాన్ని ఉక్కిరిబిక్కిరి చేయడానికి బేస్ డిసీజ్ ఇలా షుగర్ అయిపోయింది. ఒకప్పుడు మన దేశంలో, మన రాష్ట్రంలో మన ఆహార అలవాట్లు వేరు, మన జీవన విధానం వేరు, మన పద్ధతులు వేరు. మన ఆహారపు అలవాట్లోనే ఆరోగ్యానికి సంబంధించిన అనేక విషయాలు ఉంటాయి. మన జీవన శైలిలోనే మనం 9 గంటలు పడుకొని 4 గంటలు వేసేటువంటి సంప్రదాయం ఉంది. ఆనాడు మనకి ఈ డబ్బు ఆస్తుల కంటే కూడా కలిసిమెలిసి సంతోషాన్ని పంచుకున్నటువంటి క్షణాలు ఎక్కువ ఉండేవి. కానీ అవన్నీ కనుగొనలేదు. ఒకనాడు పూర్ మ్యాన్ ఫుడ్ గడక, సీల్స్, సజ్జలు కావచ్చు, నాగులు కావచ్చు, జొన్నలు కావచ్చు, మొక్కలు కావచ్చు, గోధుమలు కావచ్చు, ఇవన్నీ పూర్ మ్యాన్ ఫుడ్. ఆనాడు ఉన్నవాళ్ళు తినేటువంటి భోజనం వరణ్యం. కానీ వాళ్ళ ఉల్టా అయిపోయింది. వాళ్ళ ఉన్నవాళ్ళు తినేటువంటి భోజనం రాగులన్నం, సజ్జన్నం, లేని వాడు తినేటువంటి అన్నం ఇవాళ బియ్యం, రైస్ తినే పరిస్థితి వచ్చింది. ఎంత మార్పు వచ్చింది కోసం చూడండి. ఇవాళ మనిషి గ్రామీణ ప్రాంతాల్లో 4 గంటలు లేచిందంటే సాయంత్రం 7 గంటల వరకు ఏదో ఒక పనిలో నిమగ్నం ఉంటాడు. అంటే పని అనేది తన జీవితంలో భాగమైనటువంటి విషయాన్ని అర్థం చేసుకోవాలి మనిషి. కానీ వాటి మనిషి పనిని, శ్రమని తన జీవితంలో భాగమైన విషయాన్ని మర్చిపోయేవారు. అందుకే మన ఇంట్లోకి వస్తేనే స్విచ్ ఆసక్తి లేదు, ఆటోమేటిక్ లైట్ వెళ్తారు. మన ఇంట్లోకి వచ్చిన తర్వాత టీవీ కడుపుకోవాల్సిన లేదు, రిమోట్లో ఆన్ చేస్తున్న పరిస్థితి. అంటే మనిషి ఎంత సాఫిస్టికేట్. టెక్నాలజీ రావాల్సిందే, టెక్నాలజీ శ్రమను తగ్గించాల్సిందే, టెక్నాలజీ మనకి సంతోషాన్ని, సుఖాన్ని అందించాల్సిందే. కానీ టెక్నాలజీ మనిషి ఆరోగ్యాన్ని మాత్రం అబద్ధతలో ఉంచద్దు, అబద్ధతో పడేయద్దు. కానీ పడ్డాను మనిషి వాళ్ళ గ్రామీణ ప్రాంతాల కంటే కూడా, రూరల్ పాపులేషన్ కంటే కూడా అర్బన్ పాపులేషన్లో ఇవాళ డయాబెటీస్ ఎక్కువ ఉంది. రూరల్ పావర్టీ కంటే కూడా అర్బన్ పావర్టీ డేంజర్ ఉన్నది ఒక ఆస్పెక్ట్. అయితే ఇవాళ ఇలాంటి రోగాలకు నిలయమైపోయింది పట్టణం. కాబట్టి ఇవాళ మనకి ఇన్నో లేకుండా రాత్రిలో పనిచేసే పద్ధతి. ఇవాళ సాఫ్ట్వేర్ అని చెప్పి పిల్లలు పోతారో ఆ సాఫ్ట్వేర్లో పనిచేసే పిల్లలు 24/7 పనిచేస్తూ ఉంటారు. ఒక్కొక్కరు 12 గంటలు, 18 గంటలు, 24 hours పనిచేసే వాళ్ళు ఉంటారు. ఆ స్క్రీన్ మీద కూర్చొని వాళ్ళు పాపం వాళ్ళ జీవితం ఒక మాట చెప్పంటే సుఖము లేని, సంతోషం లేని, సౌభాగ్యం లేని జీవితం ఎందుకంటే ఇలా రాత్రి కూడా పనిచేస్తుంది. మీరు ఎప్పుడు హైటెక్ సిటీకి పోతే రాత్రి 12 గంటలకు కూడా బర్గర్ తింటూనే ఉంటాడు. రాత్రి 12 గంటలకు కూడా ఆ ఫుడ్ తింటూనే ఉంటాడు. జంక్ ఫుడ్ అయిపోతుంది, తింటూ ఉంటాడు. అలాంటి వాళ్ళు మనం ఇలా షుగర్ పేషెంట్స్ ఏదో 50 ఏళ్ళకో 60 ఏళ్ళకో జెనెటిక్గా వచ్చే వాళ్ళు ఉండొచ్చు, లేదా ఎండ మొగలో చూడని శ్రమ అంటే తెలియనటువంటి సుఖవంతమైన ఉన్నది అర్థమైంది. కానీ వాళ్ళ ఈ వర్గం ఆ వర్గాన్ని తెలియలేకుండా, పల్లెటూళ్ళు పట్టణాన్ని తెలియలేకుండా, ఉన్నవాళ్ళు లేని వాళ్ళని తెలియలేకుండా ఇలా అన్ని కుటుంబాల్లో ఆవరించిన మహమ్మారి వాళ్ళ షుగర్ అని చెప్పండి చేస్తాం. డే టు డే పెరుగుతూ ఉంది, డే టు డే పెరుగుతా. ఒకనాడు ఈ సబ్జెక్ట్ మీద పెద్ద డాక్టర్లు ఉంటారు కాదు, పట్టించుకుంటారు కూడా కాదు. ఇవాళ వెతుక్కుంటారు షుగర్ కోసం ఏం చేయాలని చెప్తుంటారు. దీని మీద అనేక మంది ఈ మధ్యకాలంలో మీరు సొమ్ము చేసుకోవడానికి, అంటే ఆ భయంతో బాధపడే ప్రజలకి సొమ్ము చేసుకోవడానికి ఇలా ప్రోటీన్ ఫుడ్ అని ఇంకా అనేక రకాల ఇస్తున్నారు. మీరు వాళ్ళ పేరులో ఉన్నది డయాబెటీస్ మీద. కానీ నేను ఒకటే రిక్వెస్ట్ చేస్తా ఉన్నా, ఇవాళ ఈ సబ్జెక్ట్ అన్నిటికీ మూలమైన సబ్జెక్ట్. ఒకనాడు మీ సబ్జెక్ట్ ఎవరికి తెలియని సబ్జెక్ట్, ఒకనాడు మీ సబ్జెక్ట్ ఎవరికి అర్థం కాని సబ్జెక్ట్, ఆదరించని సబ్జెక్ట్. కానీ ఇవాళ మీరు వెతుక్కుంటూ వచ్చే పరిస్థితి వచ్చింది. మీ సబ్జెక్ట్ని, మీ డాక్టర్ని, మీ క్లినిక్స్ని, మీ ప్రాక్టీసెస్ని వెతుక్కుంటూ వచ్చే పరిస్థితి వచ్చినట్టుగా నేను భావిస్తాను. కాబట్టి మీ బాధ్యత, మీ జీవితాలు చాలా గొప్పగా ఉన్నట్టుగా నేను భావిస్తాను. యువర్ రెస్పాన్సిబిలిటీస్ మోర్ టుడే. అందుకనే ఇవాళ మీ డిబేట్స్ చాలా ఫ్రూట్ఫుల్గా జరగాలని, సైంటిఫిక్గా, ప్రాక్టికల్గా ఉన్న విషయాన్ని కూడా కూలంకషంగా చర్చించుకొని ఇవాళ ఉన్నటువంటి మనం ఏ ట్రీట్మెంట్ అందుబాటులో ఉంది, ఏం చేయాలి, మనం తప్పకుండా చేయాల్సింది. ఒకటి వచ్చిన తర్వాత ట్రీట్మెంట్ ఒక ఆస్పెక్ట్ అయితే, రాకుండా ఉండేటువంటి మెజర్స్ ఏవైతుందో మనం ప్రజల్ని ఎడ్యుకేట్ చేయడానికి కావాల్సింది ఇది కూడా అవసరం లేదు. లేకపోతే మనం సరిపోం. ఇవాళ ఈ దేశంలో ఉన్నటువంటి పరిస్థితుల్లో అమెరికాలో డయాబెటీస్, చైనాలో ఇంకెక్కువ ఉన్నాయి. ఇవాళ దేశంలో, మన దేశంలో కూడా ఇవాళ అదృష్టం ఏంటంటే మన పాపులేషన్లో యూత్ ఎక్కువ ఉంది కాబట్టి, మనకు షుగర్ పేషెంట్స్ తక్కువ కనబడుతూ ఉందని. ఒకవేళ కనుక రెండో ఒక నాడు ఆ యూత్ అనే దాన్ని కొంత కోల్పోయి ముసల్తనంగా ఉన్నటువంటి వాళ్ళ సేకరణ పెరిగితే, యువశక్తి తగ్గితే మనం షుగర్లో కూడా నమ్మడం ఆస్కారం ఉంది. ఇవాళ అన్ఫార్చునేట్ థింగ్, బాధాకరమైన సబ్జెక్ట్ ఏంటంటే ఇలా హెల్త్ హబ్ హైదరాబాద్, ఇవాళ షుగర్ హబ్ కూడా హైదరాబాద్ పెట్టారు. ఇవాళ మొత్తం దేశంలోనే ఎక్కువ షుగర్ పేషెంట్ నగరం హైదరాబాద్ మారడం అనేది ఇది బాధాకరమైన విషయంగా భావిస్తాను. నేను తెలంగాణ రాష్ట్ర ప్రభుత్వం రెండింటినీ చాలా సీరియస్గా పట్టుకొని చేస్తాను. బంగారు తెలంగాణ, గొప్ప తెలంగాణ, దేశంలో గొప్ప రాష్ట్రంగా ఎదగాలంటే జ్ఞానవంతమైన తెలంగాణ లేకుండా సాధ్యం కాదని, ఆరోగ్యవంతమైన తెలంగాణ లేకుండా సాధ్యం కాదని భావిస్తాను. కాబట్టి జ్ఞానవంతమైన తెలంగాణ కోసం ఇప్పటికే మేము అనేక రకాల ప్రయత్నాలతో రెసిడెన్షియల్ స్కూల్స్, మైనార్టీ రెసిడెన్షియల్ స్కూల్స్, బీసీ రెసిడెన్షియల్ స్కూల్స్, ఎస్సీ రెసిడెన్షియల్ స్కూల్స్ పెట్టుకొని ఇంగ్లీష్ మీడియంలో ₹1 ఖర్చు లేకుండా నాణ్యమైన విద్య అందించే ప్రయత్నంలో తెలంగాణ ముందు బాగా ఫోర్ఫ్రంట్ నిలిచింది. అదే పద్ధతిలో ఆరోగ్యాన్ని అందించే విషయంలో కూడా, విదేశీయాల ఆరోగ్యాన్ని అందించే విషయంలో కూడా ఫస్ట్ టైం దేశంలో కేసీఆర్ కిట్ ఇన్ ద సెన్స్ వాళ్ళకు ప్రెగ్నెంట్ ఉమెన్కి రెస్ట్ ఉండాలి, మంచి ప్రోటీన్ ఫుడ్ కావాలి, మంచి బ్యాలెన్స్ డైట్ కావాలని చెప్పి ఇలా ఎకనామిక్గా సపోర్ట్ చేస్తున్న ప్రభుత్వం. ఎవ్రీ ప్రెగ్నెంట్ ఉమెన్ వాళ్ళకి 3 విడతలుగా ₹12,000, ₹13,000 సపోర్ట్ చేస్తున్నారు. అంతేకాదు అసలు ఆరోగ్యవంతమైన స్త్రీలు ఉంటేనే ఆరోగ్యవంతమైన పిల్లలు వస్తారని చెప్పి ఏ అంగన్వాడీ సెంటర్లు అయితే మేము వాళ్ళకు ఎక్సిచ్చారో మరి ఎవ్రీ డే ఒక ఇస్తాం. మేము లాక్టేటింగ్ ఉమెన్, ప్రెగ్నెంట్ ఉమెన్కి ఎవ్రీ డే ఒక ఫుడ్ ఇస్తాం. దేశం యొక్క లేదు వాళ్ళు 200 ml మిల్క్ ఇచ్చి, ఒక ఫుల్ మీల్ ఇచ్చి, ఎవ్రీడే ఒక ఎగ్ ఇచ్చి మంచి ప్రోటీన్ అందిస్తున్నటువంటి రాష్ట్ర మొత్తం కూడా ఈ ప్రభుత్వం. అట్లా ఆరోగ్య విషయంలో అనేక రిఫార్మ్స్ తీసుకొచ్చి తెలంగాణ రాష్ట్రాన్ని ఫోర్ఫ్రంట్లో ఉంచాలనే దాంట్లో, తెలంగాణ రాష్ట్రాన్ని బలమైన తెలంగాణగా ఎవాల్వ్ కావాలనే దాంట్లో మేము ఎట్లా ప్రయత్నం చేస్తున్నాం తెలుసు. కాబట్టి నేను ఒకటే మీకు విజ్ఞప్తి చేస్తున్నా, డాక్టర్లుగా ప్రజలకు ఫస్ట్ ఎడ్యుకేట్ చేయాల్సి, వచ్చిన తర్వాత సాధ్యమైనంత మేరకి శ్రమతో ఎట్లా తగ్గించుకోవచ్చు, అలవాట్లు ఎట్లా మార్చుకోవాలి, ఆ ఆస్పెక్ట్ కూడా ఎడ్యుకేట్ చేయాల్సి. ఆ తదుపరి మాత్రమే మనం ట్రీట్మెంట్ కోసం తప్పకుండా వచ్చేయాల్సి ఉంటుంది. కాబట్టి మీరు ఈ 2 రోజులు 2 days 3 days కొన్ని వన్ డే ఈ వన్ డే ఎండింగ్ సెషన్లో ఒక మంచి అర్థవంతమైనటువంటి మీరు ప్రజలకు ఒక సందేశాన్ని ఇవ్వాలని చెప్పి మనస్ఫూర్తిగా కోరుకుంటూ ఇలాంటి డిబేట్స్ మరిన్ని జరిగి ఈ రంగాల్లో ఎందుకంటే ఇంతకు చెప్పినట్టుగా ఒకసారి కిడ్నీ ఫెయిల్ అయితే 20-25 లక్షలు ఖర్చు అవుతుంది. ఆ ఫ్యామిలీ కొలాప్స్ అయిపోతుంది. హార్ట్ ఫెయిల్యూర్స్లో హార్ట్ అటాక్స్లో ఫ్యామిలీస్ కొలాప్స్ అయిపోతుంది. నాన్ కమ్యూనికేబుల్ డిసీజెస్ వల్ల డబ్బులు పోగొట్టుకోవడమే కాకుండా మనిషి కూడా పోగొట్టుకొని అప్పుల పాలై ఆ కుటుంబాలు అంధకారంలో ఉంటున్నాయి. దానికి ప్రధాన కారణం డయాబెటీస్. అంటే ఇది ఎంత ఇంపార్టెంట్ అయినటువంటిది, ఎంత స్పాయిల్ చేసినటువంటి, ఎంత ఆందోళన కలిగించే సబ్జెక్ట్ మీకు దానికి గ్రావిటేగా అర్థమవుతుంది. కాబట్టి దయచేసి ఈ విషయంలో మీరు ప్రజలకి ఈ ఇంతకు చెప్పిన 3 రంగాల్లో కూడా మంచి సందేశాన్ని ప్రజలకు ఇవ్వాలని చెప్పి ఇది దానికి దోహదపడుతుందని చెప్పి మీ అందరికీ విజ్ఞప్తి చేస్తూ మీ అందరూ కూడా శుభాకాంక్షలు తెలుస్తూ సెలవిస్తున్నా. జై తెలంగాణ.
Thank you very much, sir. Thank you for your enlightening words. I request the organizing committee to please come on the stage for the launch of the website by the Health Minister. Please. I request the Home Minister to please launch the Frontiers Diabetic Awareness and Research Society website. Health Minister. I request Dr. Jalaluddin Farishta to please felicitate our Health Minister.
May I request the entire organizing committee to please come on the stage. Organizing committee. And esteemed panel members also, please.
I request Dr. K.D. Modi to please felicitate Mr. Akbar, the Minorities Commission Chairman.
We have a group it.
Yeah. Who's the next session?
We shall be continuing with our third session. I request our panel members to. session 4, na? Immediately we are not there. There is no session. There is only one more session, lecture after this. So immediately after.
On this issue.
I think, yeah, that's working. Thank you very much for the chairpersons for introducing me, and thank you to the organizing committee for inviting me. Disclosures, I am receiving a honorarium for this talk from Novo, and I've also received help with slides and travel arrangements from Novo. So I am going to split this talk into 3 parts. Dr. FDARS has just taken us very beautifully through where the main problem lies with glycemic control in India, and this is the postprandial control. I'm going to show you some data, some of which will overlap with Dr. FDARS's, about why it's important that we get postprandial control in India. Then I'm going to talk you through how we can do it easily, and then I'm just going to show you one case to illustrate. So if you look at the Indian situation, the realities of management in India, we all have as many patients as we could wish for, perhaps more than we can safely manage. We have patients who are perhaps reluctant to transition onto insulin, who are on multiple oral antidiabetic drugs but not particularly well controlled. Add to that our reluctance to exercise, our extremely high simple carb, not just carb but simple carb diets. What we have is a high postprandial glucose level, as Dr. FDARS demonstrated. We need some way in our limited time to be able to impress upon the patients that there is an easy and convenient way of getting these postprandial sugar levels under control. Now, which way am I pointing this to keep going? This way, right, got it. Right, so if you look at the diets in India, now,
There's another one.
there's another one, okay, I'm going to have to multitask, okay, right. You can see that if you look at Western diets, approximately 40% of their diet is carbohydrate. But if you come to India, whether it's rural India or urban India, a good 70 to 75% of our diets contain carbohydrates. And so getting this carbohydrate load out of the way and being able to manage those postprandial excursions becomes even more important. All of us are extremely familiar with this Monnier slide. Essentially what this shows is that at A1Cs above 10, the dark blue is postprandial, 30% of your HbA1c is postprandial glucose contribution, 70% is fasting plasma glucose contribution. But when you want to tighten your A1c down to less than 7.5, 70% of your HbA1c is contributed to by postprandial glucose, and without getting this 70% in range, you're never ever going to be able to get your patients down to your ideal A1C. That is Western data, the Monnier data. If you look at the Asian data, and you will see whether it's an A1C over 12, 10 to 12, or down to an A1C less than 7.1, at all stages of A1C, in our Asian diet, black is fasting, white is postprandial. Postprandial glucose contributes a huge proportion. Yes, at an A1C of 7, 70%, but even if you look at an A1C around 12, there is still a 50% contribution from postprandial glucose. So especially in our Asian diets, without controlling postprandial glucose, you will not get very far in terms of A1C reduction. Okay, we're going the other way. Right, and even in well-treated patients, HbA1c remains a challenge. These 3 studies are from India, these elsewhere, and you will see that even in our best population, the majority of our patients, and this is relatively recent data, about 5 years ago, have an average A1c of approximately 8.5. So we've had about 3 different classes of drugs come into the market in the last 10 years, and in the last 10 years, we've not made a huge change in the A1C for our patients. So there is an unmet need. There is something more we need to be doing. There's something more we need to be addressing. Dr. Faraj showed you this slide. We eat at regular intervals and we spend most of the day either in a postprandial or in a post-absorptive state. So unless we get this postprandial glucose excursions under control, we will continue to struggle. So you can say, well, as I just said, we have now 6 or 8 different classes of OADs. So why not just keep adding OADs? Not a bad question. If you add, so let's assume that your patient is on one OAD, be it metformin, be it anything else. You add a second OAD, you get an average A1C reduction of 1%. You add a third OAD, that goes down to about 5%, 0.5%. And as you add a fourth OAD, that's only 0.2%. Each individual drug, we know from the evidence, gives you variable amounts from 0.65 to 0.8 to 1.2% reduction in HbA1c. But put it in a scenario where you're adding it onto a background existing drug regime, and at each stage that is very decremental. You will not see the kind of proportionate responses that you're told about in clinical trials. Insulin is something that is actually pretty powerful, and if you look at all the classes of drugs, insulin is the one that can give you a 1.5 to 3.5 and potentially unlimited. If you have a patient who's on an A1C of 16, insulin is the only agent that can bring it down. Even if you have somebody who's over 10, insulin is the only agent that can potentially get you down to 6.5, because as you add 2-3 classes of OADs, you'll see maybe a total 1.5 to 2% reduction in A1C, but not significantly more. So this is the evidence I wanted to show you, that postprandial glucose excursions are a major problem in India, in the Asian diet, and just piling on OAD after OAD after OAD does not get you to target. And we know how important it is that we get our patients to target. Then you might argue, well, why not just add in basal insulin? Surely that's an easy, simple way. We are told every single day, start with basal, start with basal. Great. This is 39,000 patients who've been just started on basal insulin, and 50 to 73% of patients treated with basal insulin fail to achieve glycemic targets in the real world. And there are multiple reasons for this, and some of these are doctor and patient related, in that we simply don't titrate aggressively enough. But whatever you do with basal insulin, remember the postprandial and post-absorptive state slides that both I and Dr. Faraj showed, you will not get good control in those states. And this is what it shows, especially in an Asian population compared to a non-Asian population. Percentage of patients achieving an A1C under 7 just on a basal insulin is very small. Compared to a Western diet, compared to a non-Asian population, in Asians the proportion getting an A1C control are very low. And this is a pooled data of 16 randomized control trials. So especially in our population, this remains a problem. We know that A1C, fasting and postprandial glucose both contribute to it. I've shown you data to show you that postprandial is a significant contributor in Indian population, and unless you have something that addresses both your fasting and your postprandial glucose, you will not get adequate control. One way of getting that, Dr. Faraz has shown you, is by using rapid acting insulin. But remember that when you start using rapid acting insulin individually, the regimens get very complex. So you have to add in a plain basal, then you have to add in 2 to 3 prandial insulins, and the regimen get very complicated. So that's one of the hindrances why we don't see these complicated regimen frequently. Now, how do we get control safely then? So yes, we can do it with complicated regimen, but is there an easier way to do it? Iragaspat, we know, we are familiar with both of these as individual components, but I'm going to talk to you about the co-formulation. You have in the pre-filled syringe insulin degludec and insulin aspart in a 70:30 ratio, which we are all familiar with various other mixes. The 30-70 mix is something that we are quite familiar with. Once you inject it in the subcutaneous depot, the degludec dissociates slowly, whereas the insulin aspart dissociates more rapidly and gets absorbed more rapidly. The degludec is present as, sorry, this is going to take a bit of time to load. I'm just going to keep going and get it all out. Right. The degludec co-formulation in the subcutaneous depot forms long chains. From these chains, zinc and then the degludec dissociates slowly, whereas the idec, you can see it's already gone. The aspart dissociates very quickly and is absorbed quickly. So when you use this co-formulation of aspart and degludec, you get two things. You get a rapid acting component that is released quickly and absorbed quickly and has a quick onset of action, and you have a slow acting component that is released more slowly from the hexamers and from the chains, and then is dissociated over a prolonged period of time to give you a stable background glucose control. And it doesn't matter in what kind of a patient, in renal impairment, in hepatic impairment, you will see that the plasma levels of IDEG are pretty standard. You don't see any great fluctuations. As with the insulin aspart, you don't see very severe fluctuations, whether it is severe, moderate, mild or normal renal function, and similarly with hepatic function. So both these formulations, the co-formulation works very well in a range of patients. Now, I'm just going to show you a few clinical trials to give you some background data on this. This is a trial in type 2 diabetes patients, insulin naive on multiple OADs. One arm was introduced to IDEG aspart, the co-formulation 3070, and one arm to insulin glargine U100. These were people who had diabetes for at least 6 months, previously treated with at least one OAD with an A1C of 7 to 10, with a BMI of 35 or less, and age over 20 years. Open labeled, because it's very difficult to blind these kind of things, and sulfonylureas, glanides and DPP-4 inhibitors were discontinued before insulin was introduced to minimize the risk of hypoglycemia. Starting dose was 10 units for both arms, and it was gradually titrated. IDEG aspart was put in with the biggest meal of the day, and glargine according to label either in the morning or at bedtime as per the patient's preference. Now you will see all through these slides the IDEG aspart is in blue and the insulin glargine in the brownish color, that there is a better reduction in HbA1c of approximately 0.4, better reduction in prandial excursions, a similar fasting plasma glucose, and less hypoglycemia. So you get better A1C for less hypoglycemia with the co-formulation. You would argue that it's not surprising that you're getting better dinner time reduction when the insulin is put at dinner time, because of course that's where you have the co-formulation, but you will see that excursions at all other meal times are also reduced proportionately. Now, and in terms of patients uncontrolled on OAD, this gave you a better chance of achieving, proportion of patients achieving HbA1c at 26 weeks was higher with IDEG aspart, and nearly 72% of patients had achieved an A1c under 7. So on the co-formulation with a single injection once daily put at the biggest meal of the day, more patients got better control with less hypoglycemia. Now this is the traditional step ladder where we wait until people fail, but this perhaps should be the optimal way of doing it. You start with lifestyle and OADs. When you start seeing a reduction in beta cell function, you initiate insulin and you titrate and optimize to maintain glycemic targets, and then you intensify. Now can you intensify with a BD mix? Yes, and I'll show you some data for that. Now IDEG aspart, although it's a long-acting basal insulin, the basal component is very long-acting, can safely be given twice daily as long as you split the same dose. So if your patient is on 20 units, split the same into 10 in the morning and 10 in the evening, and you can still get reasonable control. And you will see that when IDEG aspart is administered once daily, it takes about 2 to 3 days to achieve steady state. The orange is the rapid acting and the green is the slow acting component. And in about 2 to 3 days, you see that you achieve a steady state in plasma levels. And similarly on that side, when you give once daily or twice daily, the plasma steady state of the basal component of the insulin does not vary significantly. So this is a study in which they started patients on IDEG aspart once daily and insulin glargine plus aspart. So as I said, in the previous study you could have argued it's no great surprise that you get better A1C control when you reduce your postprandial component with a mix. But here you can't argue that because they have a basal plus a prandial, and the prandial in that case was actually increased from once daily to twice daily to 3 times a daily. So you have your basal glargine, and as required the aspart component was increased. Then you have the IDEG aspart combination. This started as once daily and at the most was intensified to twice daily. Again, type 2 diabetics over the age of 18, A1C of 7 to 10. And you will see that both achieved a similar reduction in A1C, but this is where the difference comes in. Fasting plasma glucose A1C not significantly different, but you will see that overall hypoglycemia was numerically smaller, but nocturnal hypoglycemia was significantly lower even in patients achieving an A1C under 7. So this is where the differentiator comes in. We've known since the 40 trial, going back 15, 18 years now, that when you have multiple daily doses of insulin, especially on a basal bolus or 4 times a day MDI insulin, the risk of hypoglycemia goes up proportionately with the number of injections. And you can see here that in patients who are equally well controlled, whether on an MDA or a BD mix, the number of hypoglycemic episodes is much less on the BD mix. So co-formulation of basal co-formulation versus basal bolus therapy, lower dose requirements, lower hypoglycemia incidence, right? Now, traditionally this is what we've done: OADs, then basal plus 1, basal plus 2, basal plus 3. And this is a number of visits for the patient, it is a number of titration steps, and it is also perhaps mentally discouraging for the patient to think that they're failing and there is such a lot of intensifying going on. Whereas with IDEG aspart, OADs, once, twice, 2 titrations, you're at goal. So in a way, it is less of a burden for us as clinicians, it is less of a mental burden for the patients because they don't feel that there is such a lot of titration and such a lot of treatment failure going on. Now, okay, case study. This is something that we all see. So, what do? I have a 55-year-old man, sedentary job, 8 years of diabetes, hypertension 5 years ago, on 3 OADs, atorvastatin and hypertension treatment. BMI around 27, A1C of 9.6. How many of you would advocate adding in a 4th OAD? I'm glad to see that in insulin symposium I have all the votes for insulin, right? So he's as usual with our patients, carb rich and erratic eating patterns, busy lifestyles, all of it. And what I showed you in the previous slide was this gentleman also has early diabetic retinopathy in the left eye, and I think somewhere hiding in there is a urine albumin creatinine ratio that is hypertension, and I think, oh yes, peripheral neuropathy. So retinopathy and peripheral neuropathy. So already with comorbidity. So what do you do with this patient? Uncontrolled type 2 diabetes, getting to 8 years, probably not a lot of beta cell reserve left, on 3 OADs, starting to show early complications, and with the hypertension as an added burden. So I would argue that perhaps insulin is the only way to go. Now, what would you introduce? Whether you would go for a single basal or whether you would go for a co-formulation. I think we've seen the evidence. Yes, traditionally guidelines suggest that you go with a single basal to start with, but I've shown you enough evidence to show you that unless you start getting those postprandials under control, a single basal, you will struggle to establish a decent HbA1c, especially in the Asian population. So this patient was started with a basal premix, and you can initiate or switch. So IDEG aspart, you can start once daily and you can increase to BD, or you can initiate with a basal and add it in. So administer once daily or BID with the main meals, administer alone or in combination with OADs or bolus insulin. So there is nothing to stop you from using IDEG aspart at one meal, and perhaps if they have one other carb rich meal, you could add an IDEG aspart for that meal. So we have a lot of patients in Tamil Nadu who do a brunch kind of thing at 11 o'clock in the morning, and then a dinner kind of thing around 6, 7 o'clock in the evening. The brunch is sometimes their heaviest meal, and evening they might have 2 idlis or something like that. This is not realistically a patient that I might start on a basal bolus or a BD mix, but I could quite easily use the IDEG aspart with the morning meal and maybe a small dose of prandial with the evening meal. So there are various ways of combining this. You can start at a dose of 10 units per day, or if you're more comfortable starting insulin, you can do a weight-based calculation taking into account their current HbA1c and any episodes of hypoglycemia. But wherever you start, for heaven's sake, please don't leave them at it. One of the main reasons why people do not achieve adequate glycemic control despite starting insulin is because we are not proactive in titrating. And in terms of titration, there is actually evidence to show that doctors are more conservative when titrating medication than patients. You can quite easily give patients a titration algorithm and say, if you're taking your IDEC aspart in the evening, if your fasting is less than 80, if it is 80 to 130, you can just give them a rough algorithm and say increase or decrease by 2 units. And patients are actually quite good at following these instructions. So you can ask them to take 2 to 3 morning fasting CBG readings and evening pre-dinner CBG readings in a week. Look at the average of those readings and accordingly once or twice a week titrate their IDEC aspart dose upwards. And there is evidence to show that actually patients can and will self-titrate much more aggressively than doctors, and that a titration algorithm will let patients get to goal much quicker than if doctor visits are allowed to be the only source of titration. So this gentleman started with 10, where at 8 weeks was up to 18 units of insulin, and at 12 weeks at 22 weeks. You can see a gradual reduction in the fasting plasma glucose and a gradual reduction in his post-breakfast and post-dinner readings. HbA1c gradually improved and came down to 7.3. But as is the story with all diabetic treatment, it doesn't really stop there, does it? So sitagliptin metformin was continued, sulfonylurea was discontinued, started at 10 as I showed you, increased and came to a 7.3. What happens next? We are down the road a little bit further on, and as you would expect, he has titrated up further, but there is a gradual, it's starting to show an increase in A1C. Now, we have two options here. We can make this a BD mix, or we could go in with a short acting. Now, there are no hard and fast answers. You have to, this is a dialogue that you have with your patients. This is something that you do with what regime you're comfortable with, what regime is acceptable to our patients. Right at the beginning, I said that he has very erratic meal times, that he has a very erratic lifestyle. If he's willing to inject pre-meal, then I would have put him on a BD mix. If he's unwilling to inject with every meal, then sometimes just one additional prandial dose at the time of a second big meal might be the solution. Although I'm presenting this as a BD mix, remember that in your clinical practice, there is no such thing as an ideal diabetic patient and no such thing as an ideal regime. You've really got to individualize it to your patient. So a little bit further down the line, A1C has gone up to 8, and there is an increase in his post-dinner CBG as well. So as I said, what can we do? We have various options. In this patient's case, we went to twice daily premix with a gradual improvement of his A1C. So yes, you have the option of starting, and yes, you have the option of intensifying as well with a BD IDEC aspart regime. So to summarize, in patients uncontrolled on multiple oral antidiabetic drugs, adding in more drugs doesn't really give you an incremental benefit in A1C reduction. A single premix shot gives you a significant reduction of at least one postprandial and overall basal control with a minimal risk of hypoglycemia. And a BD mix is an easy way of escalating and titrating treatment as well. So once you reach your ceiling on a once daily, it's an easy step up to go to a twice daily to obtain control. So start early, intensify, and keep titrating. Thank you very much.
Well presented, Dr. Usha. And you have very correctly stated about the varying meal patterns, not only pertaining to India, but the South India also has a different varying meal pattern. You have correctly identified it. In Tamil Nadu, you have only one main meal.
Yeah.
That's in the afternoon. And to be very specific, if you can visit any hotel or
That's
restaurant
true.
in the evening, you can't get any rice items.
Yeah.
To that extent, the things are very specific. And in contrast, in Telangana and Andhra, you find a totally different picture. So,
For such type of people, I think the insulin degludec plus aspart, the so-called Rysudex, suits very well. The only limiting point, I think, my Novo Nordisk friends are sitting over there, is the cost, which probably in course of time, it should come down. Well presented, I think.
Thank you very much.
So, thank you, Dr. Osa. Generally, for initiating insulin therapy, we all find basal insulin as the simplest way. And once we start basal insulin, it makes around 60 to 70% dent in burden of hyperglycemia. But what she rightly said is that if you feel that postprandial blood glucose is very high, then this is one more option. My feeling is that when we start insulin, our main aim is that patient should feel comfortable and he should continue it. And initially we should not worry about hypoglycemia. So if we have simple insulin that is making 60 to 70% dent in glycemic burden, and we are not worried about hypoglycemia. So in that way, starting with basal insulin therapy scores over this. But yes, I agree with you that if you have one more option, that if you have hyperglycemia, postprandial hyperglycemia, and if you are worried, then you start with this. This is also a very good option. But here, since it is co-formulation, my query is that whether we, like they have brought fast-acting aspart insulin. So are we getting co-formulation even with that also, like that will take with fast-acting aspart? Because for postprandial, if you are targeting postprandial blood glucose, then why not to target wholeheartedly?
That I think only the industry can answer, but from the data I've shown you, I think we're not doing too badly with this particular mixture either.
This is just my
Yes.
view and my feeling, I say.
Yep.
And I generally start with basal insulin, but yes, I agree
Yep.
with you that you have a good option with this.
Yeah. So there were a couple of points I wanted to make. Dr. Faraz took a poll saying what is the most important thing. I think all three on that slide were important. But if you look at the data that exists both from India and from elsewhere, doctors are more afraid of hypoglycemia than patients are. If you look at from the patient's point of view, convenience, one injection, less than one injection if possible, 0 injections, timing and flexibility are the most important things for them. They really don't care about weight gain or hypoglycemia. It is us doctors that obsess more over that because we, I think, have more knowledge and we worry more quite rightly about these things. But one patient experiences one hypoglycemia. Hypoglycemia is the most common cause for patients discontinuing insulin. Although they're not afraid about hypoglycemia before starting insulin, when you talk about reluctance and clinical inertia for starting insulin, from the doctor's side, hypoglycemia is a major factor. But when you look at discontinuation of insulin, from the patient's side, hypoglycemia is a major factor. So if you're going to put them on insulin, make sure that you give them the best possible benefit of minimum hypoglycemia.
Very excellent presentation. The patient inertia is basically on the ignorance part in terms that the doctors don't take enough time to explain them that what should be done in such periods of crisis. So that is one way. It is like if one patient develops a hypoglycemia, it's almost that you've lost the patient for good.
Yes.
You will always offer another doctor. He feels that this doctor's regimen has put me into this sort of soup. But having said that, I personally feel that these barriers are to be removed first before we initiate, because for initiating we need to have certain cutoffs. When you tell the patient that only when you initiate, when you have a complication, it doesn't make sense. We should have a track history of saying that how much of his HbA1c has gone up and what is the progression of the disease in terms of what organs have been affected, what targets have been hurt, right from the micro and macrovascular. Because when you give them a spectrum of that, they are somewhere coming to a level of understanding that, I need to take this now, this is my need. If you don't clear those barriers, we are still at a loss, because he may continue for 1 month, then the burden of the medicines go up and then he will discontinue. So I personally feel that the patient's education is a very important aspect in making the patient believe that it is for his good, because if you take the paper and 2000 there is definitely some discrepancy on that front too. So patient education is very important, and in terms of explaining how to encounter those cases of hyperglycemia and hyperglycemia, what to do in those situations, and how you should seek help, because I think that would be a balance act.
I agree completely.
And whether we believe or we don't believe, but in last 2-3 years I have seen that insulin prices have gone by 20% every year. 20% every year. This is a fact.
Look, I'm not by any means saying that co-formulation or this particular co-formulation is the only way forward. In fact, I always say this, that the right insulin is the insulin that suits your patient's lifestyle and their pocket, most importantly, because your prescription can look beautiful on paper. If the patient can't fill it, then it's doing no good, number one. Number two, 10 minutes of talking today will prevent, 10 hours of heartache and arguments later. If you educate a patient, no patient really wants to destroy their own health. If they know that this is something that's going to benefit them, and there are ways of managing the hypos and the hypers. I personally don't see many patients who prove refractory beyond a certain level of education. Most of them come around because they want what is best for themselves. And I think the final thing is, I initiate the conversation about insulin extremely early. I tell my patients, if you're lucky enough to live long enough with your diabetes, you're going to end up on insulin at some point. Whether that's temporary during some hospital admission or permanent, if you're lucky enough to live to 80, you're going to need some insulin. Most people with type 2 do. That's a reality of life. So if you open that conversation early enough and you don't use insulin as a punishment or a threat, if you don't do this, I will put you on insulin. That is the worst way of having that conversation. If you open it early enough and you open it as a way of improving the patient's well-being, most patients agree. Most people will not say no to insulin. Most people.
Any questions from the audience, please, before we end the session? There are no questions. I think we'll hand over the things to the organizers.
Sorry, do
Thank
I see
you.
a question there? No? Okay. Thank you. Thank you.
A big thank you to both our speakers for their excellent presentation. I now request Dr. K.D. Modi, sir, to felicitate Dr. FDARS Farishta, sir. Thank you, sir. I request Dr. Shrikant, sir, to felicitate Dr. Usha, ma'am. Thank you, sir. Now I request Dr. Ashok sir to felicitate our respected panel members. I request Dr. Ashok sir to felicitate Dr. K.D. Modi sir. I request Dr. Ashok sir to felicitate Dr. Shrikant sir. I request Dr. Ashok sir to felicitate Dr. Mozim. Presenters of walkathon. The following presenters have not presented their posters. Dr. Hari Prasad, Dr. Pratima Raj, Dr. Uday, Dr. Vinish, and Dr. Sai. The judges have been waiting for you. Please proceed towards your poster presentation.
Thank you, Sadbir. After the third session, now we proceed to our fourth scientific session. I invite our panel members. Dr. Pratima Raj, Dr. Venkatraman Kola, and Dr. Ashok Kumar, please come onto the dais.
So, welcome to the next session. I think the final conclusive session of this CME. We request our next speaker, Dr. Arvinda J. He will be speaking on new technologies in diabetes management, CGMS, interventions and interpretations. Dr. Arvinda J.
Good afternoon all. With so much of brainstorming since morning on DPP-4 inhibitors, SGL2 and insulins, now it's time to show some light on GLP-1 analogs. It's my privilege to present Dr. Jugal Kishore Sharma, who is from Delhi. He's a senior consultant internal medicine, Sir Gangaram Hospital, Regional Advisor, Royal College of Physicians of Edinburgh, UK, Honorary Secretary, RSSDI, Delhi Chapter, Vice President, Geriatric Society of India, Co-founder and Secretary General, Innovative Physicians Forum, Principal Investigator for many clinical trials, and speaker in many national and international conferences. We welcome you, sir.
Thank you. Thank you, madam. Good afternoon, rather good evening to all. Extremely thankful to Dr. Faraz Farishta, who have invited me here to deliver this talk. This talk of GLP-1, this should have been before the insulins. Reason being that now the cardiologists, they say that diabetes is no more a disease of endocrinologist or diabetologist. It is a disease of cardiologist and it is a vascular disease because there is endothelial dysfunction and all that. And when we talk about this, and as per many other guidelines also, they said that when there is atherosclerosis cardiovascular disease, we should start with GLP-1. If there is kidney involvement, then we should start with the SGLT2 inhibitors. So, I will in next 15 minutes, I will take you to the GLP-1 receptor agonist. Is it truly once weekly? We all know about the incretins, the GIP and GLP-1, they are the dominant incretins, intestinal hormones, released in response to food ingestion that stimulate insulin secretion in the presence of glucose. And incretins account for up to 60% of the postprandial insulin response. Insulin secretion is relatively enhanced after oral versus parenteral glucose administration because of the gut-derived factors, and that is the incretin effect. When we look here, the oral glucose, when we take the oral glucose, it goes to the stomach, from there it goes to the small intestines, and then here it comes the GLP-1, which is released from the small intestines. The GLP-1, they inhibit the gastric emptying, they promote the insulin release, they inhibit the glucagon release, and then they suppress the appetite, and these DPP-4, they degrade GLP-1. So, this DPP-4 enzyme which degrades the GLP-1. So, when we give DPP-4 inhibitors, they have an effect on the incretin, and this they stop the degradation of the insulin. And if we look here, the incretin effect which is reduced in people with type 2 diabetes, you look here, when oral glucose load is given, this is the insulin which is released, and if here the parenteral glucose is given, then this is the insulin which is released. So, in diabetic patients, there is diminution of this incretin effect. So, incretins play a key and early role in maintaining the glucose homeostasis, and this is diminished in type 2 diabetes. So, incretin based therapies target multiple defects of type 2 diabetes, including those not addressed by the traditional medications. The special thing is to not cause hypoglycemia, because still we were worried about the hypoglycemia, and they have a favorable effect on the weight as well. Examples include DPP-4 inhibitors and GLP-1 receptor agonist. The FDA approved agents, they are dulaglutide, exenatide, liraglutide, lexasenatide, oral and injectable semaglutide. Even oral semaglutide is available not in our country, outside. They have high efficacy, they are cardioprotective, renal benefits are also there, there is practically no risk of hypoglycemia, weight loss, minimal or no titration. Oral semaglutide option, as I have told, is also available, but there are certain limitations with that. The potential adverse events are nausea, vomiting, diarrhea, and in few patients, not in many, few patients, we may even have to stop these medicines. Most are injectable, although pain is minimal, and now the devices which are available, even patient does not see the needle inside. FDA black box warning, risk of thyroid C cell tumor is always there, and acute pancreatitis risk, which is very, very debatable at the present time. If you look at the overview, the approved GLP-1 receptor agonist, subcutaneously administered peptides, they are of two types, either human GLP-1 backbone or through the exendin 4 backbone. They are weekly or once daily, and they are also weekly or once daily. And here we will talk about the dulaglutide. When we look at the homology, the exendin, it's not going back. Excuse me. One slide back. So, when we look at the human GLP-1 and exendin 4 backbone, there is 53% homology. I think, oh, is it not working? We have to go back. That's all, the earlier one. Okay. So, when we look at the various GLP-1 receptor agonists, dulaglutide, the half-life is 5 days, given once weekly, subcutaneous injection, and the food requirement is none. It means it can be given at any time. Exenatide, which is BID, 2.4 hours, twice daily. Exenatide, more than 1 week. Liraglutide, 12 to 14 hours. Lexasenatide, 3 hours. But we will focus on the dulaglutide. So, these are the short acting and the long acting. Short acting are exenatide, lexasenatide. Long acting are dula, lira, sema, and the semaglutide, which is oral also available at the present time. When we discuss about the HbA1c reduction, it is highest with insulin. If you look here, GLP-1, thiazolidinedione, sulfonylureas, and metformin, they have a high reduction of the HbA1c. DPP-4 and SGLT2 inhibitors, they are intermediate. So, where is the place of GLP-1 receptor agonist in the treatment of type 2 diabetes? If the HbA1c is 6, 6.5, 7 and 8. Now, this is the typical goal of 7% HbA1c, which we look in our Indian patients. For select people, 6.5 for select people if achievable without significant hypoglycemia. Again, there is a question of hypoglycemia or other side effects. And if it is 8% goal for people with history of severe hypoglycemia. Even certain patients, limited life expectancy, elderly people or other conditions that make less than 7 difficult to attain, then even we can consider 8%. The first line metformin plus lifestyle, and if above A1C target, proceed as below, but now it is not for A1C. Established atherosclerotic cardiovascular disease, heart failure or CKD. If they are present, A1C irrelevant, and add GLP-1 receptor agonist or SGLT2 inhibitors. And if they are not present, then start with the A1C based therapies. These are the 2020 ADA guidelines. First line, again metformin lifestyle, if indication of high risk ASCVD predominates, then GLP-1 with proven CVD benefit like liraglutide, semaglutide, exenatide, SGLT2 with proven CVD benefit if eGFR is adequate. Heart failure or CKD predominates, then SGLT2 inhibitors. So, encouraging success with GLP-1 receptor agonist is we have to counsel our patients on the treatment benefits, weight loss, CVD, quality of life, and consideration in selecting injectable with once weekly options, preparing for injection therapy, first injection in office, counsel on ease of delivery devices. Of course, we have to talk about the nausea. When the patient is there on 3 drugs or 2 oral agents and sugars are not under control, if we start talking to the patient about the injectable therapy and when we start with the once weekly therapy and we demonstrate to the patient with the device that look how it is given, it is very easy and the patient compliance is much more. So, we should start with that. Once weekly dulaglutide, if you look at the structure, there is a GLP-1 analog, then there is a linker, then there is modified IgG4. This allows once weekly administration, removed and replaced alanine at position 8 with glycine, resulting in resistance to DPP-4 degradation. And the 2 GLP-1 analog to the Fc portion of an IgG4 antibody, resulting in decreased renal clearance and increased time action profile, inserted optimized amino acid link, resulting in improved binding. And this is the factor which makes it really once weekly. So, Fc fusion protein molecules are used currently to treat a wide range of disease states such as rheumatoid arthritis, organ rejection and the macular degeneration also. This eliminates the need for reconstitution and allows delivery via a small gauge needle, which is 29 G needle. Fc fusion enhanced solubility in addition to other changes, modified glycine at position 22 in the GLP-1 analog to glutamic acid, resulting in further enhanced solubility. So, the action is prolonged, the solubility is there. IgG4 selected to minimize potential for cell mediated toxicity, mutations inserted into the IgG4 minimize potential cytotoxicity also, and replacing an arginine residue with glycine in the GLP-1 analog eliminates a potential T cell epitope also. So, it is a recombinant GLP-1 Fc fusion protein consisting of 2 identical chains, each containing a human GLP-1 analog sequence linked to a modified human immunoglobulin G4 heavy chain by a small peptide linker. Approved for the treatment of type 2 diabetes, and main features are it is extended plasma half-life more than 5 days, minimal renal clearance, low immunogenic potential, once weekly dosing and solution injection. There is no constitution required. Steady state plasma concentration were achieved between 2 to 4 weeks after once weekly administration. Elimination half-life of 4.5 to 4.7 days for both doses makes dulaglutide suitable for once weekly administration. The 2 doses are 0.75 and 1.5. In renal impaired patient, no dose adjustment of dulaglutide is needed. No dosage adjustment required in patients with mild, moderate or severe renal impairment. Hepatic impairment, again no dose adjustment is needed, however needs to be used with caution. No dosage adjustment recommended based on PK with the co-administration with lisinopril, atorvastatin, sitagliptin, ethyl estradiol, or warfarin, all these other drugs. So, dulaglutide increases first and second phase insulin secretion in patients with type 2 diabetes compared with placebo. It stimulates glucose dependent insulin secretion and reduces the glucagon secretion, causes a delay of gastric emptying. The delay is largest after the first dose and diminishes with subsequent doses. It is thorough QTC study. Dulaglutide did not produce QTC prolongation at supratherapeutic doses of even 4 and 7 milligram. And profile compared between the renal impairment, no apparent difference. Then profile compared between the hepatic, which I have already told, in controlled and moderate impairment, we can look here. There was a general increase in dulaglutide exposure in the typically impaired subjects compared to control, which was not clinically significant. This clinical trial program, various award 3, award 5, award 6, award 1, award 2, 4, 7, 9, 10 and 8, and they have been all compared with various other drugs patient taking. When we come to the efficacy, the HbA1c change from baseline at primary endpoint studies without concomitant insulin, and if we look here, this one is 1.4% add on to glimepiride, then 1.42 when add on to metformin, 1.51 when we add on to metformin and thiazolidine diones, and this is add on to SGLT2 and metformin again 1.34. So, in these two trials award 4 and award 2, it has been shown with that add on to metformin and add on to metformin plus sulfonylurea, there is a significant decrease in the HbA1c levels. Award 9 and award 4, they again award 9 at combination with insulin glargine plus minus metformin, here combination with insulin lispro plus minus metformin, and again we will see this is the dulaglutide 1.5 milligram as compared to this active comparator. There is a significant percentage of patients who have achieved HbA1c target of less than 7%. Fasting blood glucose change from baseline at primary time point, again we can see that 43% reduction when award 5 add on to metformin, 43% when add on to metformin plus thiazolidinediones. And when fasting plasma glucose change from baseline at primary studies with concomitant insulin, then there is fast change from baseline 45% reduction when insulin is along with insulin glargine and or metformin. And here if we look here award 3, that shows that there is 43% with glimepiride 49%, metformin 46%, metformin plus thiazolidinediones 53%, 38% with sulfonylurea. So, there is a significant reduction or significant change in the postprandial glucose control of the patient also. Now, coming to the concomitant insulin, again combination with insulin glargine 55% postprandial change, here 76% insulin lispro plus metformin. Then weight change 2.29 body weight change from baseline 2.29 kg weight loss, here 3 kg weight loss, but here if you look here 3.61 award 4 which shows add on to metformin. Weight change from baseline, this is the body weight change from baseline 1.91, 0.87. Coming to the safety overview, just one more minute. Dulaglutide 1.5 and 1.6 increased to this is liraglutide 0.6, 1.2 and 1.8. If you look at the safety profile, it is quite safe as compared to liraglutide. And hypoglycemia, the incidence and rate of hypoglycemia are similar for dulaglutide and non-secretagogue active comparators like metformin, sitaglipizide. No significant difference were identified in incidence or rate of hypoglycemia for dulaglutide or placebo in combination with SGLT2 inhibitors, confirming the previous observation of a very low incidence of hypoglycemia with dulaglutide in combination with non-secretagogues. And with the concomitant use of glimepiride, insulin glargine, insulin lispro, the incidence and rate of hypoglycemia and comparator arms were higher. So, coming to the final point regarding this, when we talk of the patient after the oral hypoglycemic agents, we must target the patient, and now the ADA, ESD, ACE, all guidelines also say that we can directly start with these GLP-1 receptor agonists. The only thing is that one is it is an injectable therapy, second it is costly. So, if the cost is no barrier, it is supposed to be one of the best drug to start with. Thank you very much.
Thank you, sir, for highlighting the pleiotropic effects of GLP-1 analogs. I would like to know role of GLP-1 analogs, because you have said like acute pancreatitis being one of the maybe debatable risk factor. What is the role of GLP analogs in alcoholic diabetics, sir?
If the liver function tests are normal and if there is no past history of any pancreatitis or pancreatic involvement, then there is no problem, it can be given. But we have to evaluate the patient fully. If there is any history of pancreatitis, we must not use it.
Any questions invited at this juncture? If no questions, we'll proceed further.
Thank you very much.
Thank you, sir.
Now we invite the next speaker, Dr. Malik Merchant. Wants to go. I think there is a schedule change because of the flight timing, so we request Dr. Arvinda J to talk on new technologies in diabetes management, CGMS interventions and interpretation. Dr. Arvinda J.
So good afternoon, everybody. So my topic is regarding continuous glucose monitoring and ambulatory glucose profile and the clinical interpretation of ambulatory glucose profile. So first of all, greetings from Bangalore. So this is my agenda flow of my talk. The CG is the CGM and AGP. So this is all been discussed since morning, like a current scenario of diabetes. So it has been spreading like tsunami across India, across the world, especially in our country. So it has to be dealt with in a very serious manner. So what is the solution for this? Access to the essential diabetes medicine and technologies, self-management education and information are key to achieve optimal diabetes outcome. So basically education plays an important role. So taking disease on own hands is the best liberation of patient towards his betterment. So earlier, 20 years back, we discussed only when it come to diagnosis of diabetes, we only talked about fasting plasma glucose, postprandial glucose as well as HbA1c. That was the glycemic triad. Now it has proceeded to glycemic pentad. So along with the three things, the glycemic variability and the quality of life has come into the picture. The first thing is always we thought of HbA1c, which used to think about 3 months average. Now we have things to be moved on what we talk as time in range. So CGM, what is CGM? It's a continuous glucose monitoring. It is a method to track blood glucose level in interstitial fluid throughout the day and night. The CGM systems take glucose measurements at regular interval 24 hours a day and translate the readings into dynamic data, generating glucose direction and rate of change reports. So there are two types of CGMs. That is, one is professional CGM and another one is the real-time CGM. So concept, why do we do a CGM? So if you do finger prick test, that is glucometer testing, see this is what happens. So we are missing the missed lows as well as the missed highs. That is hyperglycemia as well as hypoglycemia can be missed if you are seeing only with the glucometer. So now various CGM machines are available. One is the Abbott, that is a Freestyle Libre Pro. The second one is the Dexcom's G4 Platinum. Ipro 2, that is from Medtronic. Guardian Connect. So these are the various CGM machines which are available, and there is a various software for the downloading this data from the CGMs. So rationale of CGM, that is clinical importance of technology. Why do we need that? So CGM is especially beneficial for people who aren't meeting their A1C goals, have frequent low glucose levels, are unaware of their low blood sugars, want to reduce their A1C targets without increasing hypoglycemic events, have widely variable blood sugar levels, are children or adolescents who are willing to use the device every day. So how do we monitor our glycemic control? Is it enough for managing diabetes, HbA1c? Not really. The latest concept is time in range. So if you see this, people with diabetes having the same HbA1c, see this chart, HbA1c of 7.8, both are 7.8, but values can still experience different fluctuation in blood glucose level, that is called as glycemic variability. These glycemic fluctuations have more deleterious effect on endothelial function and oxidative stress compared to constant high blood glucose level, thereby leading to cardiovascular complication. Focusing on HbA1c alone may not reveal the complete spectrum of risk for people with diabetes. So rationale for AGP using flash glucose monitoring, even frequent testers often miss significant glucose fluctuation. See, by this chart you can see this. By doing this also you can miss this hyperglycemia as well as hyperglycemia. By doing this flash glucose monitoring, we can take out the data from 14 days data, and it can be retrospectively analyzed, and accordingly the lifestyle modification and medicines can be adjusted. But only thing is the challenges of CGM data. See, because if you take Libro Pro, it's a CGM machine where the 14 days data will be collected. You can see this 14 different colors here, 14 different chart here, but it's very difficult to analyze what is happening here, isn't it? So what has to be done? So once these things happen, using the AGP, that is ambulatory glucose profile, it simplifies the complex data sets into manageable snapshots. So this is what it happens. The data density brings its own problem, but when it is condensed, it looks very simple and very easy to understand for the doctors as well as when you are explaining to the patients as well. So ambulatory glucose profile, it's a constructed from a model day plot which collapses glucose data over several days or weeks. The data is plotted according to time as if they occurred over 24 hours. AGP is a visual snapshot of patient's typical day, revealing the patient's hypoglycemia, hyperglycemia, as well as the glycemic variability. So this is how the ambulatory glucose profile looks like. So if you see this 14 days chart, which is condensed into a simple chart, you can make out when is the patient. See, at the early morning at 2 o'clock to 4 o'clock, patient is experiencing hypoglycemia, then it is relatively well maintained. After breakfast he is going for hyperglycemia. See this inter-day glycemic variability. Then at the night once again the hyperglycemia pattern. This is how very easy, if you show this chart to the patient, it is very easy to explain. You can tell him, see what you are eating in breakfast. You are eating 10 idlis? No, come on. You are eating biryani? No, come on, you have to reduce. I can't treat you if you are eating like this. See this, that is how it is happening. So this makes your life easy when you are explaining to the patients. So AGP, if you take, it's a differentiator. So ambulatory glucose profile is an innovative way of looking at patients with diabetes to be enabled with ample information that give insights into daily glycemic profile of the patient and help in making well-informed decision in context with the diet and exercise. Means by this chart, you can tell you are eating excess of carbohydrate, cut down on that. You can eat more of proteins. You can explain to the patient. Or as a doctor, you can say this particular patient has got postprandial hyperglycemia. We have to titrate the dosage. We have to change the medication. We have to address the issue. Or he may go in for night time, at early morning hypoglycemia. We may have to reduce the insulin dosage. So depending upon the patient profile, by looking into this AGP, we can do that. So this is how the typical AGP graph is a model. If you take, this is a chart taken for 14 days. This is a graph, model day plot of all the data of the patient up to 14 days. This talks about the overall glycemic profile of the patient over the period of wear, with a 14-day graph having potential predictability of next 90 days. So this allows detection of trends and pattern as well as hidden glycemic issues faced by the patient. So this is the pattern showing individual days. It can be made very easy like this. So what is the important thing is it gives a warning as well. The red one says that patient is going for hypoglycemia. So you don't want the patient to go in for hypoglycemia, whether he might be in a tablet or whether he might be on insulin. You don't want the patient to go in for hypoglycemia. So you know what time he is going for hypoglycemia. Like that, the appropriate corrections has to be done. And in the way, in long term, you can avoid long-term cardiovascular morbidity as well as mortality. So this is the typical traces, the 14 days traces you get. looks very busy, but if you see into that, it looks very, very easy. After the end of 14 days, you get a collective data as well. The first one is the average glucose level. The second line is the time in range. Third one is the hypoglycemia events. And the fourth one is the hyperglycemia. This is how, from the first day to the 14 days, you know how the patient is there, glucose level is fluctuating, and ultimately you can combine it and explain to the patients. So what is time in range? It's a standard. Now the next concept is not HbA1c. In future, we'll talk in terms of time in range only. In the coming years, it is becoming a big area where we address to the glycemic variability has to be taken very seriously. It's a standard measurement in diabetes management that tracks the amount of time a person glucose in their target range, with 70 to 180 milligrams being the standard range. Spending more time in range helps minimize both short and long-term health complications from going too high or too low. So what is the rationale of time in range? Hypoglycemia and fear of hypoglycemia presents always a challenge. When you are managing a diabetes, hypoglycemia is the biggest challenge, especially when the patient is on insulin. This time in range helps you to assess that in a very easy way. There are two studies which has been done which tells people with diabetes whose A1C levels were less than 7% spend more than 90 minutes per day with a glucose level less than 70 milligrams per deciliter. Same thing was seen with impact study as well. So relationship between time in range and the HbA1c. This is commonly asked, is there any relationship? How do we correlate? If you see this particular chart, time in range is 0 means HbA1c 12.1 straight away. Basically, if you will come across so many patients where the HbA1c level is 14 or 15, you can think that that patient's 24 hours glucose control is not there at all. At the same time, if the patient's HbA1c is 5.9, you can say 80% is managing well. So this is what we call as time in range. Average, if you take 7, we want HbA1c of less than 7, that is 6.7, that says patient 70% in 24 hours is blood glucose in a normal level. So parameters obtained on a daily glucose summary report using Freestyle Libre Pro tells about the average glucose, time in range, time below target, and time above target. The key benefit, these are the key benefit. If you see the insight from AGP, you can see this chart. Glycemic profile of the patients helps you to identify hypoglycemia, hyperglycemia, and glycemic variability, and impact of various foods on glycemic levels. When you have the 14-day chart, you can tell the patient what food to be not taken, what food to be taken by showing the graph in front of him. So that makes your life easy. And you can also tell the impact of exercise also, timing of exercise and intensity of exercise, meal spacing in relation to exercise. All this can be explained in sitting in front of the patient just by showing the graph. So what is the benefits for HCP? That is benefits for doctor. A 14-day graph clearly shows a pattern in glucose level which enables doctors to more quickly detect potential problems such as hypo and glucose variability. The daily glucose summary provides information that HCP needs to assess and fine-tune therapy and lifestyle modification. What are the benefits for the patient? The information is presented in a simplified way that makes it easy for patients to understand. The graph provides a link between day-to-day behavior and glucose level, thereby involving the patients in taking back control. So what are the clinical interpretation? How do you interpret as a doctor? So the glucose data is organized into 5 smooth curves. The main thing to be concentrated is the dark blue line, that is the median, which tells about how the glucose is there. And this navy blue one, this particular wave is called as the interquartile range. And the light blue one, that is the yellow one, you can see 10 to 90, it is a 10 to 90th percentile of 8, that is 80% of all the data, that is interdecile range. So what does the normal look like? If you see this chart, is it normal? Is it normal? Yeah, you think it is normal, but if you closely observe, there is a little bit chances of hypoglycemia here as well. So what is normal? So once again, if you see, it can be hypoglycemia here. So if you want a proper perfect control, see this. This is the perfect one. There is no fluctuation. Interquartile range is fine. Interdecile range is fine. The median curve, there is no much fluctuation, which is well maintained in the time in range. So if you see this particular chart, what is happening? Early morning there is hypoglycemia. After breakfast and around 6 o'clock it is increasing. So we have to do, if you see this here, both the interquartile range and the interdecile range is wide. Here not only medicine but lifestyle modification has to be addressed and explained to the patient. So when you do that, this can be a smooth curve. So if you see, once the exposure is there, what happens? These are the things to be covered. And when you are explaining about the IQR, that is interquartile range and interdecile range, here if you talk to the patient sitting in a simple words, you tell them this is the point, it is happening in a 14 days period, you have to address these issues, we give medicine accordingly, but we from your side we expect a perfect lifestyle modification with a perfect diet and exercise. So when you tell that this is like how the HbA1c time in range, it flows on. So if another example showing that where the patient is going for hyperglycemia at 10 o'clock in the morning, around 6 o'clock, 6 o'clock in the evening, at the same time the most dangerous thing is in going for hypoglycemia. So what you can do here, you can ask the patient to reduce the carbohydrate rich breakfast, or at 4 o'clock ask him to, around 2 o'clock ask him to take a bit of snacks, and you according to doctor's wish, according to the chart, we have to adjust the medication so that in such a way we can reduce this postprandial peak as well as stop this hypoglycemia. This makes our life easy as well as the patient's life easy. So AGP derived treatment priorities, if you see this is a very beautiful chart. If you see this, it is not in the range at all. If you see this median curve, it is above the range. So what has to be dealt here? So we have to address this issue very quickly. So first one is to reduce the variability. There is a much of variability, isn't it? You have to reduce the variability. So you have to adjust the lifestyle modification and medicine accordingly. Improve his stability like this. Then reduce the exposure to glucose level. So ultimate aim to bring his level between 70 to 180. This should be the goal of the treatment with diet as well as exercise as well as medication. So glucose variability, the spread of glucose value. If you see this, this is the big value. How do you calculate this? Median curve is moving up and down here. So this has to be addressed. The shape of the median curve can provide insight into the glucose variability. You can see here, once again the lowest glucose, here once again the between 4 a.m. to 8 a.m. the tendency is for hypoglycemia. So average hourly change we should be around 12 milligrams per deciliter. So variability, if you see IQR should be 51, anything less than 51 it is normal. Anything IDR, anything less than 88 is normal. Anything above 8, we call it as glycemic variability. How do you calculate this? The top one minus the bottom one. Here also for top one minus the bottom. It's very simple. When you start using it, you will come across this, and it's very easy. You put couple of patients, and definitely when you are explaining to the patient, it is very easy to understand. So if this is the interquartile range, if you see that, this is the interdecile range. So when you are telling about explaining to the patient, the variability differences is glucose from one day to the another. So hypoglycemia, most important is we don't want our patient to land in hypoglycemia. So any particular things, if the patient is on basal insulin, there is every chances patient may land up in early morning hypoglycemia. So once you are suspecting this, when you put this patient on this, he is having early morning hypoglycemia, but throughout the day his sugars are high. He is not in time in range at all. So you have to adjust the medication or change the insulin or add on oral hypoglycemic agent according to the needs of the patient. So this is what it happens. So the risk of overnight hypoglycemia if curve is unchanged and glucose exposure is reduced. Just 2 to 3 slides, just showing an example. One, is it in time in range? reasonably in time in range. Target assessment just above target. If you say it's just above target, variability not much variable, but still it is not totally normal. Any risk of hypoglycemia? There is no risk of hypoglycemia. This particular chart explains like this. Example 2, see this. The target assessment substantially above target. See here, above target. Degree of variability very, very high. Hypoglycemic events, yes, there is a hypoglycemia chances are there. So all these things can be corrected by just doing this 14-day graph, that is AGP with ambulatory, that with Abbott Libre Pro machine. The example 3, another one, if you see this, rarely above target, means it is reasonably okay chart, but low variability is also there. Still it is okay, but he is developing hypoglycemia in the early morning. So this has to be addressed. So this is the final chart. When you are assessing this, there is a simple chart, very easy to understand. You see this and put a tick or plus and appreciate this. This is what I call it as kundali of the patient. For marriage, they see the kundalis and they say match and all those things. Your kundali matches and all those things. Here you can say this is called as a medical kundali, means jataka. So you see the jataka, you tell this is your diabetes jataka. This has to be corrected for a long-term benefit to reduce your mortality and morbidity. So, ladies and gentlemen, the future of diabetes management is technology. Get used to it. It's easy if you use it and understand. March ahead and use it like your smartphones for better care of your patient. Thanks for patience hearing.
The role of CGMS has been established in like type 1 diabetes and patients with more fluctuating blood sugar levels and more with hypoglycemic effects. The other scenario where the role of CGMS is emphasized more is gestational diabetes, where the management of sugars is monitored very closely.
Gestational diabetes, pre-diabetes, obesity, all these areas it can be developed.
Yeah.
Suppose one patient comes to you, doctor, I have a strong family history of diabetes. I don't want to get diabetes. Can you tell me something? Okay, you put you're not on any medication. Okay, we'll put you on 14 days Libre Pro. I'll assess you after 14 days. When he comes to you, okay, see, this is the things, these are the junk foods you are eating. This is the alcohol you are taking. This is the idli you are eating. So all these things has to be reduced. See, early morning you are not doing any exercise. This is how the pattern is happening. So do 1 hour of exercise. Avoid this junk food. You can avoid diabetes.
Yes. Maybe in future it can replace OGTT.
Yeah, sure,
yes.
Sure, yeah.
Thank you, sir. It was an interesting presentation.
Thank you.
Now the panel is open for any questions from your side. If no, then we'll proceed further.
So, I request Dr. Maulik Merchant to come on to the dais and deliver his lecture. He is the director of Mind Care Institute, consultant to Oakard Hospital and Ali Khan Hospital, and is the principal investigator in numerous multicentric and multinational trials, speaker in many national and international conferences. Please take over.
Thank you, sir. I'm the odd man out here. I'm a psychiatrist. And I'm going to speak on depression and diabetes. Usually, we are used to hearing a lot every day. And when given an opportunity, it is, we don't lose this opportunity to keep talking, but I will limit myself to this 15 minutes. I won't define diabetes because defining diabetes over here will be like singing a nursery rhyme. So I'll just directly go to what is depression basically. I envy you physicians. Your lives are a little easier than us. You all have blood tests to diagnose diabetes. the patient walks in and you prick him in this finger and know what the status of his disease is. We are not so lucky, and I don't think that we will have any test for diagnosing depression, at least in my lifetime. Depression is diagnosed basically based on symptoms. And if you see the symptoms, they affect three aspects of a person. It affects, there are emotional symptoms, there are physical symptoms, and there are cognitive symptoms. The emotional symptoms basically are sadness of mood, irritability, anxiety at times, lack of interest in any kind of activity. The physical symptoms are basically appetite change, change in weight, weight loss or weight gain, increase in appetite or decrease in appetite, sleep disturbances. Usually we have a misconception that in depression patients don't sleep well, but there are atypical depressions where patients sleep more. Fatigue, lack of energy, psychomotor changes, they become either very, very agitated or they become very, very slow at times. Feelings of worthlessness or guilt. Then there are cognitive symptoms, which are difficulty in concentrating, difficulty in making decisions, memory problems. A lot of our patients with depression come and complain to us about memory problems. And the worst outcome is suicide. Now, they say that there is a close link between diabetes and depression, and there is ample of evidence for this. In a normal population, it is seen that around 3 to 5% of the population will be affected by depression. But in diabetes, this rate increases to around 15 to 20%, which is quite a bit. We have been talking about a lot of complications of diabetes, like neuropathy, like retinopathy. I don't know what's the prevalence of neuropathy and retinopathy in diabetics, but almost 15 to 20% of your patients with diabetes will definitely have depression. And if it is unrecognized and untreated, then it will have very, very bad outcomes for the patient. His emotional and physical health will get affected. It is said that around 31% of the diabetic patients will have significant symptoms of depression. Even if they are not diagnosed as having major depressive disorder, they will have a lot of symptoms of depression. There is a reverse link also. People with depression have an increased risk of developing diabetes. So there's a bidirectional link between depression and diabetes. Diabetes can cause depression and depression can cause diabetes. But when they both co-occur together, it's a disaster for the patient. So if you see patients' own health ratings, and these are the conditions in which the patients have rated their health, the worst health ratings have been when patients have got depression and diabetes both together. Even if they have, a lot of other chronic illnesses, but this deadly combination, their own ratings for their own health are the worst. So it is common, and it just not increases the morbidity, it also increases the mortality. There is another slide for it which I will go through later. Also, the physical health and mental health of patients with depression and diabetes are worse when they co-occur with each other. Health-seeking behavior. If you will see this chart, patients with depression and diabetes are reaching out more to doctors, are making more visits to hospitals because of their condition being co-occurring together. There are also a lot of studies which show that just having depression and diabetes increases the complications of diabetes also, independent of other variables like coronary artery disease. A lot of patients who have depression and diabetes have a higher chance of developing coronary artery disease, of having retinopathy. Even in children with diabetes who have got depression, they have a higher chance. And it's vice versa also. having micro and macrovascular problems increases the risk of having depression. So there's a bidirectional link in both of these. There is a greater risk of having heart disease, higher body mass index, hyperglycemia, worse diabetes self-care, and increased mortality risks. So it's a vicious cycle. You know, if it's untreated, it goes on and on. There is depression which leads to other complications and diabetes, poor self-care, high sugar levels, then body image problems which causing depression, complications causing depression. So it's a vicious cycle which goes on if depression is also not treated with diabetes. So this is a slide which shows definite increase in mortality due to depression. Here we see that people who have got depression and diabetes, they have a higher mortality than who have just depression and they are not diabetic. So what is the link between depression and diabetes? Some argue that there is a behavioral link. People with depression are associated with reduced physical activity, which increases the risk of obesity and consequently type 2 diabetes. And also patients who have got depression have got poor self-care. So no matter how much we educate them, no matter the best insulin that you might give to them, the best OHA that you might give to them, but if he is depressed, he is not going to do any lifestyle modification, maybe non-compliant to his medications, and thus have a worse outcome in spite of you giving the medicine which has got the best evidence for treating diabetes. But there is also a biological link. Depression is a phenotype for a range of stress-related disorders, and we know that it causes disturbance in the hypothalamic pituitary adrenal axis, causing increase in cortisol levels, and prolonged stress, being in stress for a prolonged period of time predisposes a person to diabetes. Also, there has been now some evidence that some types of depression are basically caused by inflammation. There is a book that has come out which is called as The Inflamed Mind, which argues that depression, certain types of depression are due to inflammation. And also I hear that a lot of you all talking about obesity, diabetes being one of the causes being inflammation. So there is a biological link also, not just a behavioral link. So there is a bidirectional association between depression and diabetes. What are the problems that we might come across in patients of diabetes and depression? One is diagnosing them. Lot of them will come with physical complaints, and we might attribute those physical complaints to diabetes and miss the diagnosis of depression. Lot of them will come with complaints of aches, pains, fatigue, neuropathy, all those kinds of symptoms that they might come up with, and we may just attribute it to appetite changes, we may just attribute it to diabetes but not look at the other symptoms. It is very important not to also look at the emotional and the cognitive symptoms of depression in patients. So just the physical symptoms, we might miss the diagnosis. So we need to ask the patients about their emotional state. How do they feel? Have they lost interest in activities that they were doing earlier? Their cognitive issues. If these symptoms are not elicited, there are high chances that we may miss depression in these kinds of patients. Also, patients with depression and diabetes will come with lot of unexplained medical symptoms. इधर दुखता है, उधर दुखता है, गैस होता है, ऊपर का गैस ऊपर रहता है, नीचे का गैस नीचे रहता है, पेट का पेट में जुलाब होते रहता है, and you know, these kind of symptoms, and we sometimes just dismiss these kinds of symptoms as just nonsense. But we need to, in these kinds of patients, we need to explore that if they have been suffering from depression and that is why they are having these unexplained symptoms, just giving some symptomatic treatment will not help them. They will come back again with similar kind of symptoms. Also, adherence to treatment will be a big problem in these kinds of patients. Unless their depression becomes better, they will not be compliant to your medications. They will not be compliant to your lifestyle modification. So it's extremely important that we diagnose depression properly in these kinds of patients. These are the patients which will also look at a magical cure and blame the doctor for not treating them adequately. Because of their emotional state not being in a proper manner, they will keep saying that, you know, you've been giving me medications, but I've not been improving. And these are the patients who will go for doctor shopping. They go from one doctor to another doctor, one facility to another facility, just looking for a miraculous cure. But the underlying depression may be the cause for them not getting better. So symptoms we've already discussed. I will quickly go over. One important thing that I would like to highlight over here is that sometimes we realize that there is something wrong with this patient. This patient is emotionally disturbed, and this patient may be depressed. And of course, we at times quietly sneak in an antidepressant for a patient, you know, an escitalopram or a sertraline or a duloxetine. But does that really help? Does that really help? It's just another pill in the list of all the medications that we are giving him. I think we need to talk to the patient, make the patient realize that yes, you have been having emotional symptoms. There is a mind and body connection, and that is causing you a lot of symptoms. We will try to help you to overcome your emotional problems, but I am giving you this medication for this purpose. Quietly sneaking a 25 milligram of sertraline or a 10 milligram of escitalopram will not do any good, to the patient. You know, it may reduce some anxiety here and there, but the somatic complaints will keep occurring again and again. So this is very, very important that we talk to the patient, make him realize that these are your emotional symptoms which is causing you these physical kind of problems. Lot of my colleagues tell me that, you know, oh, you all have all the time in the world, you know, we are busy people, we see 50, 60, 100 patients. You psychiatrists are the people who have all the time in the world to sit and talk to the patients, and we don't have any time to diagnose these patients with depression. Actually, it has been proven that it doesn't take a very long time to diagnose a patient with depression, at least screen a patient for depression. There are tools available, there are self-administered questionnaires that are available. These are like your glucometers. We also have we've simplified our lives to a certain extent. We have these questionnaires which are self-administered, like the PHQ-9. They're just 9 questions, and the patient self-administers it. Your nurse in your clinic or your assistant or some medical professional in your clinic can score and send you this report along with the glucose levels, at least to screen if the patient has been having depression. And depression is not the only mental health condition which will affect diabetes adversely. We also need to look at other symptoms like anxiety, like other problems. Lot of our patients with diabetes and lot of our patients with depression will have sexual problems. But are we doctors ready to talk about their sexual health? We ourselves, when they start talking, we sometimes just ignore and just give them some random medication. So other aspects of mental health are also important. But yes, depression is not very difficult to diagnose. In fact, the sensitivity and specificity of just 2 symptoms, they say that if you just ask these 2 symptoms, little interest or loss of pleasure in doing things and feeling down or depressed, if the patient answers one of them also, okay, it's a good enough screening tool to indicate that the patient may be suffering from depression. So just 2 questions also have a sensitivity and specificity over around 80 to 85%. So it's not very, very time consuming. It is easy to diagnose and quick to diagnose also. I just have 8 seconds left. Okay. So management, yes, only medications is not the cure for depression, as only your OHAs and insulins are not the cure for or better control for diabetes. We need to look at therapies. I think for emotional eating, a lot of patients will have comfort eating. You know, cognitive behavior therapy works problem solving therapy works, motivational interviewing. It's a technique where we increase the motivation of the patient to improve treatment adherence. These things are very, very important. I walk into a endocrinologist clinic and he has a foot care center and an eye care center and everything. I wish he would have a psychological care center which would benefit the patient even more, you know. So I urge you all that, you know, take services from psychologists. It will benefit your patients quite a lot. In addition to having foot care and eye care, the mind care is also very, 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 very important. Choice of antidepressants, yes, we need to know a little bit of intricacies of these. We need to choose antidepressants which are weight neutral, which do not have sexual side effects, which are maybe not hepatotoxic and toxic to the kidneys. So first choice is always an SSRI or an SNRI. If the patient has got other symptoms, we could choose the right kind of medication. Like if the patient has got neuropathy, as it is, we prescribe the patient SNRIs like duloxetine or desvenlafaxine, which helps in neuropathy also and in depression also. We need to avoid medications which will increase appetite. There are antidepressants which increase appetite. One of them is mirtazapine, which increases the appetite quite a bit and causes weight gain. Some antidepressants can be used in patients who have got sexual dysfunctions, like bupropion, or like adding a buspirone to your SSRIs can definitely help. Thank you. I'm open to questions if there are any.
Thank you, Dr. Malik, for your excellent lecture. So, if any questions from the audience?
So I would like to bring out 2 points. Like clinicians, we would be more careful while dealing with type 1 diabetic patients, where depression is almost more common when compared to type 2 diabetes patients, because it starts early in younger age groups and maybe secondary to insulin therapy or so, but it is observed more common in type 1 diabetes patients.
I agree with you. At such a young age to deal with such a chronic illness which is going to be lifelong is a stressor in its own self. So I agree with you. These people need to be looked more closely.
And your take-home message to divide the deadly combo of 2 Ds, diabetes and depression, and to introduce one more D, that is divide it and add delight in the lives of diabetes, is well taken, sir. Thanks for an enlightening presentation.
Thank you.
So, we invite Dr. Narayan Rao, who is the professor and HOD, Andhra Medical College, Vijayawada, organizing secretary of AP State Medical Conference, Vijayawada, received Dr. Kotta Parinama Lakshmi Memorial Gold Medal, Oration Award from IMA, delivered lectures at various national and international forums. Sir, kindly come over to the dais.
I'm here, sir.
Right.
Thank you, respected chairpersons. And today we are going to discuss in the next 15 minutes the role of the gut as well as heart and kidneys as target organs, as well as complications in the type 2 diabetes mellitus, and we'll see whether there is any evidence to show that alpha glucosidase inhibitors, particularly in the form of acarbose, can intervene in these target organs. First of all, let us look at the gut and diabetes, and now the new data is emerging over the last 5 to 10 years, showing that there is a large place for involvement of gut microbiota as far as it being the causative factor as well as a target for treatment. Previously, we used to think that whether it is metabolic syndrome or insulin resistance or type 2 diabetes mellitus, we used to consider only 3 factors, that is the genetic background as well as the environmental factors and the kind of diet one is trying to eat. Now there is a lot of data and evidence which shows clearly that gut microbiota also plays a very important role in the initiation of insulin resistance as well as progression of onset of diabetes and complications. And we also know that there are two kinds of gastrointestinal gut microbiota. One are the potential probiotic which are helpful in the form of particularly the lactobacillus and bifidobacterium. And there are some potentially harmful bacteria which could be anything which we commonly see in our day-to-day clinical practice like Pseudomonas, Proteus, Staph and Clostridia species. And is there any evidence to show that there is any dysbiogenesis or alteration of gut microbiota in type 2 diabetes mellitus? You have data which has been published in the journal Nature in the year 2012. This is a metagenome-wide association study which has clearly shown that in all type 2 diabetes mellitus patients, there is a degree of microbial dysbiosis, and they have clearly shown that in type 2 diabetes mellitus patients, there is a decrease in butyrate-producing species of bacteria, and there is definitely an increase in various types of opportunistic pathogens. And whether you can do anything about this dysbiogenesis as well as alteration in the gut microbial flora in type 2 diabetes mellitus by using acarbose, let us see whether there is any evidence. This is a small study which has been published in the Journal of Diabetes in 2015. About 90 diabetic patients, type 2 diabetes of Chinese origin, has been divided into two groups, and in one group they have given these patients acarbose at a dose of 150 milligrams per day, and in the rest of 36 patients were treated with the usual medications without the addition of acarbose. Before the study onset, they could demonstrate that in all these 90 patients, there was levels of bifidobacterium were lower than the control populations, and there is increased evidence that there is pathogenic bacteria is more commonly present in these patients in the form of Enterococcus faecalis. After treatment for 4 weeks with acarbose, they have clearly demonstrated that there is definite increase in the levels of useful bacteria in the form of bifidobacter, and there is decrease in the concentration of the Enterococcus faecalis in these people with type 2 diabetes mellitus who has been treated for 4 weeks with acarbose. Not only that, they have also shown that there is decrease as far as the harmful chemical substances in the form of tumor necrosis factor alpha, lipopolysaccharide and high sensitivity CRP are concerned, and we have a lot of evidence to show that all these factors which have been mentioned over there are clearly identified as cardiovascular disease markers for modification. And there is, these are all hypothetic pathways which have been implicated in the causation of cardiovascular diseases in type 2 diabetes mellitus patients. Particularly, let us see whether there is any relation between these pathways and whether we can positively address them with the usage of acarbose. Particularly, let us look at the short chain fatty acid pathway. And it has been clearly demonstrated by this time that acarbose is the only alpha glucosidase inhibitor which pushes the polysaccharides, that the complex carbohydrates, into the colon, and thereby it increases the colonic bacterial mass, and it also facilitates production of short chain fatty acids and hydrogen gas by fermentation of these complex carbohydrates in the lower large intestine with this kind of bacteria which has been abundantly proliferating with the usage of acarbose, and it has been clearly postulated that with the short chain fatty acid production and hydrogen gas production is going to positively affect the cardiovascular disease risk factors, and maybe we will be able to achieve good cardiovascular outcomes with the usage of this particular drug. And that is as far as the gut and acarbose is concerned in the presence of type 2 diabetes mellitus. Let us simultaneously see whether there is any evidence as far as heart and cardiovascular benefits with the usage of acarbose is concerned. These are all various kinds of studies which have been there, and we all are familiar with this, particularly the Helsinki policeman study and the DECODE study and the Honolulu heart program. What all these studies which have been mentioned on this slide here have clearly demonstrated is that the postprandial hyperglycemia of any given patient is clearly associated with worse cardiovascular outcomes. So we also know at the same time that alpha glucosidase inhibitors, particularly acarbose, clearly addresses the postprandial hyperglycemia and thereby reduces the postprandial hyperglycemia. Not only that, it has been also identified through various references which have been mentioned on the slide here that the blood lipid profile, particularly the triglycerides levels, are adversely affected whenever there is hyperglycemia, particularly the postprandial hyperglycemia. And it has also been clearly demonstrated that whenever a patient suffers from an episode of postprandial hyperglycemia, the blood reaches a state of hypercoagulability. And there is evidence showing that postprandial hyperglycemia is also associated with increased intima media thickness And there is evidence to show that postprandial hyperglycemia is independently associated with decreased myocardial blood volume and blood flow. So all these factors are clearly cardiovascular risk factors. And it has also been identified that there are 5 important factors whenever you are trying to treat a patient with type 2 diabetes mellitus. These are known as and identified as glycemic pentad. One is the fasting plasma glucose and the other is postprandial plasma glucose. The other one is hemoglobin A1C, and then there is hypoglycemia. And then there is a term called glycemic variability. The previous 2 speakers have also addressed that. And out of all these 5 which are known as glycemic pentad, you can clearly see that at least the 3 factors can be positively affected with the usage of acarbose. You can reduce the postprandial hyperglycemia, that is the main action of alpha glucosidase inhibitors in the form of acarbose. You can also reduce the mean amplitude of glycemic excursions, which has been clearly identified as a predictor of negative cardiovascular outcomes. And we also know pretty well by this time that hypoglycemia is not very common with the usage of acarbose. And it has also been shown that use of acarbose is associated with some amount of weight loss, some amount of harmful cytokines in the form of C-reactive protein, plasminogen activator inhibitor, and all those things mentioned on those slides. So by virtue of its effect on the postprandial blood glucose reduction and by virtue of its action on this kind of cytokines, probably acarbose affects positively all the cardiovascular risk factors, and thereby we may be able to achieve better cardiovascular outcomes. These are all surrogate endpoints, and not to say that there is no direct evidence which I have shown up to now, which has shown a direct link between the usage of acarbose and positive cardiovascular outcomes. But there is a recent real-world study which has been published, which has clearly linked that acarbose, particularly in comparison with the sulfonylureas, have clearly demonstrated its benefits as far as cardiovascular outcomes are concerned. There is a study which has been published very recently, last 2 years back, in the 2018 issue of Journal of Clinical Endocrinology and Metabolism. This is an interesting study in the sense that this is a real-world study which has shown the data lasting for about 11 years. And what they have done is they have tried to identify patients with a metformin background. In one group of patients, they received sulfonylureas, and in the other group of patients, they have received acarbose. The only difference being acarbose or sulfonylureas. So the primary endpoints being all-cause mortality and hospitalization for various cardiovascular events. Let us see the results. Results are very interesting. There is significantly lower risk with acarbose plus metformin for hospitalization to major atherosclerotic events, either in the form of a non-fatal myocardial infarction or a non-fatal stroke. You can clearly see the difference between the acarbose group and the sulfonylurea group. There is a 31% relative risk reduction. And hospitalization due to ischemic stroke, again, a 32% relative risk reduction. And even if you look at all-cause mortality, again, there is a clear-cut difference and the benefit to the level of about 24% relative risk reduction with the use of acarbose. And hospitalization for myocardial infarction was also reduced. Hospitalization due to heart failure, I think there is a 9% RRR, but not statistically significant. Hypoglycemia, of course, as can be expected with the usage of alpha glucosidase inhibitors in comparison with sulfonylureas, are definitely better in the group of patients who has received acarbose. So the conclusion from this study is acarbose as an add-on to metformin was associated with lower risk of major atherosclerotic events, particularly ischemic stroke, and all-cause mortality and myocardial infarction was also much better in the treatment arm, which was been compared with another arm wherein sulfonylureas were used. This is another study. I think Bayer had a lot of hope on this study before it was published. This is known as ACE study, wherein they have selected patients who already had a cardiovascular event, but not diabetic yet, but with impaired glucose tolerance. Though, of course, this study was neutral, what it has clearly proved is that if you have a patient with a cardiovascular event or at high risk of developing a cardiovascular event and the patient is simultaneously having impaired glucose tolerance, at least this particular study has clearly proved that it is cardiovascularly neutral, but at the same time, you can also prevent these patients from going into a full-fledged type 2 diabetes mellitus. So let us look at the kidneys and diabetes and acarbose. So nowadays, it has been clearly identified by this time that low-grade albuminuria, which is in the range of 10 to 13 milligrams per gram of urinary albumin-creatinine ratio, has been identified as a potential risk factor for future development of diabetic nephropathy and increased carotid intima media thickness and high prevalence of carotid artery atherosclerotic plaques and increased plasma triglyceride levels. This is again another interesting study from a Chinese population. It's a small study And again, they have taken this data from the March trial, which has been published quite some time back. Nearly about 600 newly diagnosed treatment-naive type 2 diabetes mellitus patients have been selected. All patients had a urine albumin creatinine ratio which is slightly less than 30 milligrams, and again they have divided these patients into two groups. In one group, the UACR was below 10, and the other group was between 10 to 30. And they have studied these patients with the use of acarbose versus metformin. And you can clearly see that in these patients, urinary albumin creatinine ratio was significantly decreased in subjects taking acarbose compared with those taking metformin. My idea is not to say that acarbose is better than metformin, but after metformin, acarbose could be a valuable add-on drug in these kind of high-risk patients. And please remember, there is hardly any dose reduction which is needed for renally impaired patients with acarbose until the EGFR falls to a value of around 25 milliliters. You can safely use acarbose without much dose reduction. So, from this small presentation of mine, I would like to emphasize on the following points. As far as effects on gut is concerned, modulation of gut microbiota composition and function have the capacity to alter the metabolic profile in the desired favorable outcomes or desired favorable direction, and there is evidence to show that the useful bacteria can be increased and the harmful bacteria can be decreased with the use of acarbose in type 2 diabetes mellitus patients. And effects on heart because of its virtue of its action on the postprandial hyperglycemia and various other cytokines which are harmful for cardiovascular outcomes. It has been found that acarbose is a useful modality of treatment in type 2 diabetes mellitus patients to achieve good cardiovascular outcomes. And in the kidneys, by virtue of its effect on the reduction of urinary albumin creatinine ratio, probably you can expect to have some favorable effects on renal outcomes as well. And thank you, chairpersons and audience, for your patience.
Thank you, doctor, for your excellent lecture. So, any questions from the audience?
Yes, sir. Yes, sir. Yeah, the only issue, I perfectly agree with you that there is some flatulence and there is a question mark whether you can use this particular drug in all type 2 diabetes mellitus patients. Sir, I have got 2 points to mention here. For a period of time, we have observed that when we are co-administering acarbose with metformin, surprisingly it has been found that patients seem to tolerate the combination of metformin and acarbose, which both independently are gastric irritants. For some reason or the other, they seems to be tolerating that better. Coming to oglibose, which is supposed to be tolerated much better than acarbose, the point with oglibose is there is hardly any scientific data as far as its efficacy and its potential as far as reducing adverse outcomes, whether it is related to kidney or cardiovascular system. There is hardly any data, sir.
Thank you, sir. Thank you for that wonderful interaction. We now come to the last lecture of this session. I request Dr. K.D. Modi, sir, who is a senior consultant endocrinologist in Care Hospital, Nampalli. He was a treasurer for Endocrine Society of the India. He was an ex-treasurer, general secretary for Hyderabad Society of Endocrinology, and principal investigator for many clinical trials, and is a seasoned speaker in this part of the world and nationally and internationally. And he will be speaking on gliptins on a cardiac safe gliptin. Dr. Modi.
So, first of all, I thank and congratulate Dr. Faraz and team for having this very interesting diabetes symposium. And good thing is my presentation is last, so everybody will be relieved after that. So in brief, the agenda of my presentation would be that allogliptin that is available now in Indian market. So whether is it required or not, how it stands against other gliptin. We have standard gliptin, saxagliptin, sitagliptin, vildagliptin, and when vildagliptin has become off patent, do we really need one more gliptin? Is it like other gliptin, like teneligliptin, evogliptin, or it has something extra? And being like biosimilar compound in India, how it stands against innovator brand. So these are the three issues I will be addressing. We know that in best of the best center world over, diabetes control is very, very difficult. Even if you take Mayo Clinic data, Jocelyn data, the maximum patient which come under A1C target of 7% would be 65 to 70%. And in India, most of the data is most of the center, maximum 35 to 40% of patient only they reach A1C target of 7%. So that means something is missing in armamentarium of controlling hyperglycemia. So whatever good agent, whatever new medicine, effective and safe, if we get, that is always welcome. And diabetes, this has been discussed several times, that it is increasing like anything, prevalence is increasing, morbidity is increasing, complications of diabetes are increasing, and that is people say that it is just a tip of the iceberg. Whatever number of patients you are seeing, similar number are undiagnosed. So problem is huge, and we really need pharma industry along with lifestyle modification to prevent it, and those who get diabetes to manage them. And that's why we need a newer agent. And among all agents, like we have modern sulfonylurea, we have gliptin, we have SGLT2 inhibitor, we have insulin, we have GLP-1 analog. But among all, I would say that gliptins, they hit at multiple level of pathogenesis of diabetes. Like they are insulin secretagogue, they address alpha cell defect, they address gut factor, they address central brain factor. So they address pathogenesis of diabetes at multiple level, and while prescribing, they are issueless. Like even in young patient you prescribe, elderly person you prescribe, you are not worried. So that's why gliptins have become very popular among all oral anti-diabetic agent. And side effect profile also, if you see, that they are minimum. Yes, SGLT2 inhibitors have come out with many cardiovascular benefit, renal benefit, but whenever you prescribe SGLT2 inhibitor, you will have to think 2-3 times that can I prescribe this agent to patient? How is his EGFR? You will have to instruct him about genital mycotic infection and those side effects. You have to instruct him that whenever you are admitted, don't take this patient or don't take this medicine. If you have febrile illness, diarrhea, vomiting, time being, you stop these agents. So SGLT2 inhibitors are good. They have a definite advantage. But while prescribing, they are not issueless. You cannot prescribe just blindly, just like that. But that is not there with DPP-4 inhibitor. DPP-4 inhibitor, all the positive factors are there. That they are weight neutral, and they are effective. Hypoglycemia is minimum. There are no major side effect. And one more advantage that has come recently into limelight is that DPP-4 inhibitors are more effective in Asian patient. Why? Because people have found that DPP-4 enzyme levels are higher in Asian patient, including Indian patient. So if concentration of DPP-4 enzyme is high, then DPP-4 inhibitor will work better, and that is agreed everywhere. And A1C reduction is found more in Asian patient as compared to non-Asian patient in case of DPP-4 inhibitor. So these are the benefits of prescribing DPP-4 inhibitor, and US FDA has approved 4 DPP-4 inhibitor. One is sitagliptin, other one is saxagliptin, third one is linagliptin, fourth one is alogliptin. So these are 4 US FDA approved gliptin. Vildagliptin, it never it is used everywhere in Europe, but it never came in US market. Reason could be anything. And if you see the pharmacokinetic of these all 4 standard gliptin, then alogliptin stands out. Why? Because if you see, bioavailability is maximum with alogliptin. Protein binding and other things are okay, but bioavailability is maximum with alogliptin. And specificity also is maximum. Specificity for DPP-4 enzyme means it will not work, it will not act against this DPP-8 and DPP-9 enzyme. So side effect related to this allergic nasopharyngitis all will be minimum with alogliptin. So side effect wise also this is good. And DPP-4 inhibition is maintained after post dose. Maximum inhibition is 90% and more than 75% of inhibition is maintained. So in that way also alogliptin scores over this. And there are various clinical trials as a monotherapy of alogliptin in uncontrolled diabetic patient versus placebo, in along with metformin. So there are randomized, prospective, well-controlled trial approving the efficacy and safety of alogliptin. And luckily we were also part of the one of this trial where metformin uncontrolled patient, alogliptin was given for 2 years, patients were followed. So this was the study. So these are very good study. Alogliptin has been tried as monotherapy in along with metformin failure patient, along with sulfonylurea, and even in insulin requiring patient also. So all these are big trial supporting this molecule. And maximum data, if you ask, maximum data is for 3.5 years. These are Japanese study where alogliptin was given. So, and in real life study also against linagliptin, sitagliptin, vildagliptin, meta-analysis is there where alogliptin is found equally effective in regards to A1C reduction and adverse events. So we have sufficient data proving non-inferiority to other gliptin for alogliptin molecule. And if everybody will ask for CVOT trial is there or not. So CV outcome trial, like we know that with teneligliptin it is not there, evogliptin it is not there. But alogliptin, very good trial, examine trial is there. That is a full-fledged CVOT trial where Indian patients were also included. Like total 400 patients were there from India and 33 center. And my hospital, Care Hospital, was also one of the, though I was not involved in that, but that was also one center. So all across world patients were included, and finally, like patients were divided into two groups, and ultimately, like this is the flow chart, 2,700, so big number of patients. And and here also it was proved that alogliptin is these were primary endpoint, death from cardiovascular, 3-point miss, non-fatal myocardial infarction, non-fatal stroke, and secondary endpoint and safety endpoints. And everywhere alogliptin was proved non-inferior to, and all these were very high risk patients, like patients inclusion criteria was that within 90 days somebody should have cardiac event. So if somebody had cardiac event from 15 days to 90 days period, in this gap patient was picked up. So all these were very high risk patient, and it was a conclusion was that alogliptin was not found to be associated with excess of CV event in patient with type 2 diabetes and recent acute coronary syndrome as compared to placebo. So it was non-inferior, and there was hue and cry about heart failure. So this there was re-evaluation about for the examine study, and there also ultimate conclusion in patient with type 2 diabetes and recent acute coronary syndrome, alogliptin did not increase the risk of heart failure outcome. Here numerical difference was there about the heart failure related admission, but statistically it was not significant, 85 versus 79. And lastly, so this proved that this molecule has CV outcome trial, heart failure related data is also not against this alogliptin. And lastly, we don't have innovator molecule. Innovator molecule is basically from Takeda, and that's why they have a study, and they have a molecule in combination with pioglitazone in USA, like pioglitazone with alogliptin. In India we don't have. So Takeda company, they never brought this molecule. So Indian company, they have made this, and they have some bioequivalence data that I will show you lastly, that what are these bioequivalence data. So in fasting state as well as in fed state, they have shown some bioequivalence study, and where they presented to DCGI two studies on 25 milligram and 12.5 milligram. And beautifully we can see that overall this efficacy of drugs bioequivalence falls to original molecule in fasting state and in postprandial state. So that much proof is there to support this newer molecule. So ultimately what I say is that alogliptin is a good standard number one class gliptin, which has so many prospective randomized control trial about its efficacy and about its adverse event safety profile. And alogliptin pharmacokinetic wise is a wonderful molecule in comparison to other gliptin, and to support it, it has a CV outcome trial including heart failure related data. So we can trust and use this molecule for our uncontrolled diabetic patient. Thank you.
Alogliptin with pocket friendly price in future would may overtake sitagliptin or vildagliptin in future, sir. With
I don't think they have kept a very reasonable price.
Yeah, I'm saying patient friendly price.
Yes.
Yeah, maybe 12 rupees or so.
Yes.
So it's like it may overtake teneligliptin, which doesn't have any trials to support it.
And I didn't show, but even in renal patient also with minor dose modification, we can use it. Elderly patient also you can use it.
Any questions from the audience? We conclude this session. Thank you so much, sir, for the lucid presentation.
Thank you.
Thank you, sir, for the presentation. Now I request Dr. Ashok, sir, to felicitate Dr. J.K. Sharma, sir. I request Dr. Ashok to felicitate Dr. Narayan Rao, sir. I request Dr. Venkat to felicitate Dr. Arvinda. Now I request Dr. Pratima to felicitate Dr. Malik Merchant. Finally, for the felicitation of panel members, I invite Dr. J. Farishta, sir, to come on the dais. Dr. Farishta, sir, will felicitate Dr. Ashok Kumar, sir. Dr. Farishta to felicitate Dr. Pratima. I request Dr. Farishta to felicitate Dr. Modi. Sir. Dr. Farishta to felicitate Dr. Venkat. So thank you, Dr. Farishta. At the end, we have kept best of the best. We have a quiz which is beat your best. And the bonus is whoever answers even one right answer will give a prize. Even one right answer, you get a prize. I invite Dr. Zia on the dais to conduct the quiz. We have only 10 questions. We will finish in 5 minutes. Whoever raises his hand first would be given the option. So the process is we have only 10 questions, and as soon as Dr. Zia questions, you have to raise your hand. Whoever raises his hands first would be given the opportunity. Every answer has a prize, so hold your seats tight. Can all the postgraduates please come and occupy the front rows? Because it would be easier for you to get spotted.
That's better. It's better to hear on the phone. Yeah, yeah.
So all the questions from this quiz are from the sessions of the day. So as a bonus for attending the entire program and listening patiently,
Yeah. Good evening, everyone. So, are we ready for the quiz? Yeah. The first question, can we have it displayed or? Yeah. According to ADA 2019, the following is true for type 2 diabetes screening. A is asymptomatic adult with TG more than 150. B is fastest finger first. Okay. So if anybody has his answer before I read out the question, they can raise their hands. Yeah, yeah. Aleem is there to help me out in spotting you out. You have an answer? You have an answer for this?
Madam has an answer.
Yeah, please, madam.
Option 4.
Option 3.
Mic up.
We can have one more mic. Can we have one more mic? Can we have?
Next slide, Jayant. Next slide.
Answer.
Hello, hello.
I think madam said answer. So we take one answer. We take one. We take close it. How do we do it? Okay. so yeah. Somebody else? 3. How many for 3? Do we have any other answer? Sir, do you have an answer, sir?
Yeah.
Do we have any other answer?
Any other answer?
Up A.
Any other answer?
D. Yeah. Can you?
Yeah, if you can explain out why you're saying this thing. No explanations. Fine, okay. Okay, fine. Shall we close it? Yeah. The answer is B. Yeah. Nobody gets the prize for this. Yeah.
The quizmaster gets the prize for every round.
Okay, fine. We'll just go with the second question. This is question. Can we have the question number 2 on the board, please? Next question, please. Yeah. According to the Rotterdam criteria, all including the diagnosis of PCOS is except. So, how many for B? How many for B? So who said B first? She gets a prize for this. Yeah, please. Yeah, and introduce yourself. Tell your name. Give your mic. Give a mic. Do we have mic there?
I'm Dr. Srividya from Medicity Institute of Medical Sciences, General Medicine PG first year.
Right. Nice. You have spotted the right one. So can we have a round of applause for her? Now we'll proceed on to the third question. Can we have the third question on screen, please? Yeah, sorry. Which of the following DD? Okay, very good, yeah. Who's the first one? What's the answer? D. Fine, he gets it. You have to be first. Make sure you are first. Fastest finger. Fine. Congratulations. Yeah. Fourth question. This is on any fingers before I read out the question? Fine. I'll read it out then for you. We have there. Tell me. Yeah. No, first he was the first guy, yeah. Tell me.
Dapagliflozin we can use, sir. Sodium glucose.
What?
SGLT2 inhibitors we can use.
Pardon me?
SGLT2 inhibitors, sir. Next.
Right. You got it right. Please, round of applause for him. Absolutely right. Your name, please. And you are from?
Umakant from MRMC Kalaburgi, sir.
Very good.
Umakant.
Nice, yeah. Good. Come and take your prize. Please. Yeah, we'll go to the next question. Yeah. Can we have the next question on board, please? I'm looking for fingers here. Any more hands? Yeah. Pardon me? Please give mic to him, no? No, first him.
B.
Sorry. C, who was she was the first to say C?
C, sir.
Yeah. What's your name?
Sir, Dr. Swati, sir, from MRMC Kalburgi.
Yeah, very good, Swati. So you have got 2 MRMC guys taking away the prize. Nice. Come down, please. In the meanwhile, can we proceed on to the next question, please? Swati is getting a prize. So who wants the next prize now? Who's going to have the next prize? Sir. We'll take answer from Pras, sir. Do you have an answer, sir? Pardon me? Yes, you are absolutely right. Just come and collect your prize and introduce yourself also. Next thing. Can we have the next question? Question number 7. Great. He was the first one. Once again, you get a chance to answer.
Acarbose, D.
Right, you are right. Please. This time you got it right. Please come. Got last 2 questions. So we'll got 2 more prizes to be taken away. We got 3, but we have got only 2 questions. Yeah. Double prize. Achha. The last one gets double prize. Acha, 2 prizes. Okay, fine. Good. Any fingers? Any guesses? Who is the first one? Again? Yeah, please. Yeah, you are right, please. Yeah. So next, can we have the next question? No, we have got 2 more questions to go. Got 2 more questions to go. Please. You raised your hand, please. Answer? Can I have one more answer, please? Who said B? Madam gets a prize. Madam gets a prize for this. And can we have the last one? Last one. Come on, put in your efforts. Now the last one. Yeah. Yeah, again. What you said? D. Yeah, please. So he's the guy who's going to collect 2 prizes today. He's already received 1. Yeah. So one more question do we have? Now one question. Yeah. Who is the first person to enter the hall?
Okay, so the 2000 ADA ESD guidelines said after metformin, you divide it into 2 groups. What are the 2 groups? When you want to start a SGL2 inhibitor or a GLP-1 analog, whom do you want to give? What class of patients after metformin? We don't have a price for you. No options. This is no options. This we want to see if you have cardio. Get up and tell. I don't want cardiovascular and what? Non-cardiovascular? What? Brain? Peripheral vascular disease? Who said renal?
So Modi gets, yeah, Musa gets prize for us. So thank you everyone.
Now we will be calling one by one for poster presentations. All of you, one by one, we have the list. Please.
Just come to the dais, like we want name of the poster.
Can we have the poster presentation committee on the stage, please?
Yeah. Dr. Gautam, Dr. Srikanth, please.
Dr. Vikram, Dr. Gautam,
Dr. Srikanth,
Dr. Srikanth, and Dr. Zia.
We have to read out. So please.
I will call. You can start giving. This is the.
We have.
Yeah. So there is a memento for all the participants who have done the poster presentation. We wanted you, all of you have done very hard work, so you deserve that.
We had a very good poster presentations today. So everybody had put in their efforts quite efficiently. The presentations were very good. The topics were quite different. It was quite a good amount of representation from PGs from different colleges. And like after discussing, I think Dr. Gautam has a list of 2 persons who had made it. Total of.
No, we have it. We have a list.
Right. I do have it.
I have a list. You don't have from where that comes. But
Yeah, so you can go.
Yeah.
You also can go. So, Krupali, can we have Krupali on the stage? She has presented on? Yeah, on what? K&D? Okay, so, okay, ketone prone dies. Yeah. Can we have that background? Just keep the background on with the logo. 5 minutes. With the logo. Yeah, just keep this. Maruti. Maruti. On insulin auto antibodies. Swati on sixth nerve palsy. Dr. Priscilla. Her paper is on ankle brachial index. Dr. Bhim Reddy. Dr. Amya, sorry. We still did not disclose the prices for crack the code, so PG is wait, and then top two poster price is also there. Just we will finish it off. Dr. Anuradha, our paper is on Gouty Tophi. Big applause, they have put a lot of effort. Dr. M. Mudassir on MDR in tuberculosis. Dr. Sai Arun has presented a paper on Hirata syndrome. Dr. Uday on myasthenia gravis in postpartum. Dr. Hari Prasad on mitochondrial myopathy. Dr. Vineet on neuromyelitis optica. So now we are left with 4 prizes for the day. Prize 1, prize 2 for the poster presentation and 2 for the crack the code. So the first prize goes to, any guesses? For poster, any guesses? I want to shout my name, but I cannot. Now I am not there, so now I feel sorry about it. So it goes to Dr. Mudassir. On MDTR tuberculosis. Any guess for the second prize? Dr. Krupali on Tata Bye Bye Diabetes. So she had a very good paper to present. I think it was a neck to neck for the judges to decide, but KPD. She has come from all the way from Gulbarga. So for the crack the code, the Shiva Kumar from Medicity. Do we have him? On his behalf from Medicity, somebody can take. Dr. Sindhu Harika, do we have her? Okay, since we do not have her, I think people who are still waiting, I will go for the next name. Meher Babu. For crack the code. Do we have Murtuza Qureshi? Okay, so Dr. Shraddha can come and she's there, so she can come and take the prize for crack the code. So she was the third. Since she has shown the perseverance to stay down, she gets the prize. स्टेज पे आ जाओ फिनोस हाँ मैं कंपनी वालों को बुला आप लोग स्टेज पे रहो स्टेज पे रखो नहीं अभी फोटो कौन बोल फोटो कौन बोल नहीं हो गया अभी खत्म दे दिए दूसरे को दे दिए नहीं सॉरी So last but not the least, I want to thank you all for making this a success. And then yes, next year we are planning to have a 2-day program. One day we got some suggestions from our seniors that it would be a post-graduation day. So one whole day will be for the postgraduates and the next day will be for the practicing physicians and consultants. So I want to thank you all. First I want to thank the faculty which has come all the way right from Delhi to, we do not have Dr. Sabir, he was supposed to join us to Kerala. Thanks to all the faculties who have made it possible. Without this, it would have not been possible. So a big hand to all the faculties. Next, it becomes